Hi, everyone. I'm Dr. Katie Healy, a Cancer Prevention Fellow in the Health Communication and Informatics Research Branch within the Division of Cancer Control and Population Sciences here at the National Cancer Institute. Along with my colleagues, Dr. Robin Vanderpool and Dr. Vidya Vedam, I'm delighted to welcome you to the first day of the NCI Global Cancer Stigma Research Workshop. Stigma is the process by which certain human conditions are labeled as socially undesirable and linked to negative stereotypes, resulting in separation or social discrimination of the affected condition or individual. Over the next 2 days, we will focus on this process as it relates to cancer, body of work that is substantial and diverse. Our goals for this workshop are to highlight current research in the cancer stigma space, as well as to identify gaps in this body of research and to articulate new directions and questions for the cancer stigma research community to consider and address. In putting together this workshop, we work to include a wide range of topics that consider the entirety of the cancer control continuum, a range of cancer types, a diversity of populations, and a variety of settings. We are proud to have over 25 speakers and moderators that include patients, clinicians, advocates, and researchers. We appreciate the contributions of everyone who is taking part in this workshop and would particularly like to acknowledge Jim Pantelis and Carolyn Taylor, two individuals who during today's sessions will be sharing their time and personal experiences as cancer survivors and advocates. In addition to our wonderful speakers, we have a number of others to thank for helping make this workshop possible, including the NCI Office of Advocacy Relations, the Center for Biomedical Informatics and Information Technology, the Division of Cancer Control and Population Sciences, the Center for Global Health, Evelyn Obat, and Cindy Chan. A few housekeeping things before we get started. Given the large audience, about 200 people taking part in this workshop, we ask that everyone turn off their cameras and mute their microphones during speaker presentations. Please feel free to turn your cameras on during the Q&A portions of the day and to use the raised hand feature if you would like to ask a question. We are lucky to have so many speakers and participants. However, this makes keeping time and balancing conversation especially important. With this in mind, during multi-presenter sessions, of which we have several today, please hold all questions until the end of all speaker talks. If there are questions during the presentations, please put them in the chat using @ and the name of the speaker if the question is specific to a particular person. Session moderators will collate chat questions and share them with the session speakers during the Q&A. With that, I'd like to once again welcome everyone to this workshop. We are excited and curious to work and learn with you over these 2 days. At this time, I will now introduce Dr. Satish Gopal, Director of the NCI Center for Global Health, who will share some remarks to get us started. Dr. Gopal.
Great, thanks so much, Katie. Let me share my screen. All right, so I lose visibility when I start to present, so I'll just assume that everything is working, but please let me know if it isn't. So thanks again so much for inviting me to give just a few brief opening remarks, and more importantly, to attend and learn at this important meeting. As Katie mentioned, I'm Satish Gopal. I direct the Center for Global Health at the National Cancer Institute, and I first want to appreciate colleagues from our center and the Division of Cancer Control and Population Sciences for organizing this workshop, and all of you for attending. As you all know, cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020. This figure is, of course, increasing dramatically, and up to 70% of these cancer deaths occur in low and middle income countries, with a significant proportion of these deaths being preventable. Stigma is associated with many of these cancer cases and deaths, and indeed the WHO has identified stigma as having a hidden burden of disease that is not as easily measured. Therefore, understanding and measuring cancer stigma is critically important to develop stigma reduction interventions and reduce cancer burden globally. Cancer stigma is disgrace or public disapproval associated with cancer, which may be especially important in settings where the etiology, treatment, and outcomes for cancer are not well understood. Stigma has been widely studied globally for infectious mental health and neurologic diseases, but much less is known about cancer stigma worldwide. And I think that really speaks to the importance of workshops like this Cancer stigma can be broadly classified into three types. There is self or individual stigma, which is concealment or internalization of negative societal views about a cancer diagnosis. Public stigma refers to a set of negative attitudes and beliefs that motivate individuals to fear, reject, avoid, and discriminate against people with cancer. And systemic or structural stigma is defined as societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being for cancer patients and or their family members. Before coming to NCI, I was an oncologist and physician scientist in Malawi, and we certainly encountered these forms of stigma, even if we didn't exactly frame them using this language. As just one example, this study shown at right was led by a Malawian early career researcher, Christopher Stanley, who conducted qualitative interviews with families of children with lymphoma to understand reasons for treatment abandonment. Many of the themes emerging from these interviews were likely related to these multiple forms of stigma. For example, self-stigma may have led to a loss of hope, even for children with curable cancers engaged in care, who in many cases were actually responding to treatment. Public stigma may have been experienced by prevalent community opinions actively discouraging families from continuing to seek treatment. And systemic stigma may have occurred from the extreme centralization of cancer services in Malawi, which required families to make enormous sacrifices to overcome immense logistical challenges to receive treatment at tertiary hospitals, unlike many other healthcare services that were available closer to home. Reflecting the importance of cancer stigma, the World Cancer Declaration has identified 9 targets to be achieved by 2025, with target 5 being to reduce stigma and dispel harmful myths. Despite its importance, global cancer stigma research remains a nascent field with limited tools to rigorously and reproducibly identify and measure cancer stigma in diverse contexts and inform evidence-based interventions to reduce cancer stigma. And let me just reiterate my gratitude for DCCPS and CGH convening this meeting and allowing us to really map what's known in this area and what some of the important gaps and opportunities are. Stigma can also, as you all know, manifest at all stages along the cancer continuum. The belief that prevention efforts are futile can disincentivize individuals from accepting and adopting evidence-based cancer prevention like vaccination or screening or healthy lifestyle choices. The physical changes that often accompany cancer treatment, like weight loss, alopecia, mastectomy, colostomy, can leave patients feeling isolated and embarrassed and less willing to adhere to treatment. And again, this is what I encountered daily in my pre-NCI life. Post-treatment challenges that often arise for cancer survivors, like sexual dysfunction or difficulty retaining employment, can be a cause of continuing cancer stigma, even for those who may have been cured. And finally, the possibility and often assumed fatality of cancer, whether or not this assumption is medically correct for a given patient, often discourages candid conversations at any phase of the cancer experience. To better understand the current landscape of cancer stigma research, we recently reviewed NCI-funded projects addressing this topic during fiscal years 2008 to 2018. We identified a total of 49 unique projects, most of which were in the US or in other high-income countries, despite a series of workshops and funding opportunities over many years shown on this slide. Seeing an opportunity, therefore, to better support cancer stigma research globally, engage interest in this important topic among the extramural research community, in 2021, the NCI developed an administrative supplement funding opportunity to support global cancer stigma research, which funded 8 new projects. We are thrilled that we will be hearing from some of these investigators today about their ongoing work to understand and address global cancer stigma. Those 8 projects are shown here, and really the goals of our funding opportunity were to elucidate the etiology and perpetuation of cancer stigma, measure the impact of cancer stigma on physical and mental well-being and associated health behaviors of patients, identify mechanisms and pathways by which stigma is a barrier to cancer prevention, treatment, palliation, and survivorship, and develop interventions to reduce cancer stigma and improve cancer outcomes. The 8 projects shown again here span various cancer sites and targets various points in the cancer care continuum. These projects also provide unique contextual insights into the nature of cancer stigma in diverse LMIC settings and populations. So let me now end my remarks and open this workshop. Our goal at the NCI is really to share knowledge, identify research gaps, and engage in dialogue regarding how to collectively make progress in the global cancer stigma field. Some specific future directions that we have been thinking about are highlighted on this slide just for your consideration. But we really look forward to learning from all of you during the sessions today and tomorrow to inform and refine our thinking moving forward. Thank you very much.
Thanks, Satish. That was fantastic. Any questions, quick questions for Satish before we head off to the next session? All right. I think everybody agrees with you on the importance of doing carrying this research area forward, Satish, and thanks again for your remarks. So I'm Vidya Vedam. Good morning, everyone, and welcome again. I am here to to introduce and moderate the next session on the impact of cancer stigma. This will be our first session, and we have a fantastic line of four panelists to talk about different contexts in which stigma occurs and around the globe. And with that, we also, as Katie had rightfully mentioned, we would like for all the questions to be answered at the end of the session. So please use the chat feature, or we will be actively monitoring that for additional questions. And then I also wanted to take a minute and say that I won't be doing very detailed introductions of our speakers, so we'll do brief introductions of all speakers, but I highly recommend that we have considering the stellar lineup we have of speakers, please visit our website and learn more about the research they do and all of the fantastic, highs they have achieved despite limited funding in this area. So thank you, everyone. Our first speaker is Dr. Laura Nyblade. Dr. Nyblade is a fellow and senior technical advisor on stigma and discrimination in the Division of Global Health in the International Development Group at RTI International. Her talk is titled, What We Know About Cancer Stigma in India. Laura, please take it away.
Thank you very much. Can you see my screen?
Yes, Laura, go ahead.
I'm going to take that as a yes. So good morning, good afternoon, good evening, wherever you are in the world. Thank you to the organizers for inviting me to speak. This is an honor, and I feel a little bit like an imposter at this meeting because most of my work is in the area of HIV stigma and populations associated with HIV, and most lately in deaf and hard of hearing stigma, but taking the lessons we've learned. I have done some work on cancer stigma in India, and so I'm going to share a bit about that. I'd like to recognize co-author Ishu Kataria, who is a senior public health researcher based in India with RTI India, who helped prepare this and works on many different aspects of cancer in India. I won't spend a lot of time. I just wanted to sort of ground us in the background of cancer in India. I think Dr. Gopal has already sort of set the stage for that, but just to say that cancer is prevalent in India. And I just sort of highlighted here female cancers because the studies that we did were largely with women. So just wanting to note that it is an important issue in India. And in general, the incidence and mortality has been increasing over time. We know that screening is low, diagnosis is often late. Public cancer facilities in India are fairly overwhelmed. There are private cancer facilities. However, the cost can be very prohibitive. I think we already had the discussion about Malawi and the distance that people have to travel. And so cancer often leads to catastrophic health spending. Stigma has been identified as a barrier to care across the cancer control continuum in India. With that said, as has already been mentioned, there are actually very few studies on cancer stigma, and they have been with small samples and have been largely qualitative. And qualitative studies are incredibly important, and they help us really understand what's going on. But as I've learned from working in HIV stigma field for 25 years, we can't measure it. We can't get resources to actually address it. So the quantitative measurement of stigma being very important. As part of when we got this wonderful invitation, Ishu actually did a very quick literature search to see, because our work is a couple years old in India, and we didn't find much, which I think speaks to the gap and why we're all here. We found 6 studies on cancer stigma in India, and again, this was a rapid, not a systematic review, including the 2 that I'm going to present on. So there is clearly a need for us to do more work. I'm going to present, now I'm going to turn to share a bit about what we've learned in 2 different exploratory, and they are small scale studies in sites in 2 states in India. And given the diversity and size of India, I want to underscore that what I present is exploratory and not at all representative of India, just of the samples, that the populations that we interviewed. That said, I do think these 2 studies, one qualitative and the other a small survey, illuminate some important aspects of cancer stigma and hopefully provide a starting point for additional work, but also for us thinking both about measurement and interventions in this context. Just a quick run through the methods. So on the qualitative side, we had 2 qualitative studies in Karnataka. One was around breast cancer that was done out of a tertiary hospital. It was in-depth interviews with patients, primary caregivers, and healthcare providers. And the second was based in a community setting, and it was focused on cervical cancer. We had in-depth interviews with women who had undergone screening, healthcare providers, and community leaders. And then we also had focus groups with women, and then focus groups with husbands. The quantitative survey was a very small study. It looked at dyads from the CARS surveillance study from Delhi and Chennai. So these were cancer patients and their primary caregivers. And again, it was a very small sample, 20 of each, but I think it starts to give us some indication of sort of what cancer stigma is looking like in this population. Coming from the HIV field and really from, I straddle the research and programmatic worlds, a big focus on implementing programs to reduce stigma. I kind of have this summary of the qualitative results that really focuses on thinking about what are the actionable drivers that are popping up in this data that we can start thinking about interventions around and measurement. And so in the HIV field, we've come to land on what we call the immediately actionable drivers of stigma. And this has really been to allow us to think about what we can do now, what are the levers of change that we can grab hold of now and make change in the experience of stigma while we're working for that larger social change. So I think, as we all know, and then I think that visual that was shown already is stigma is very structural, and we need larger social change. But what are the things that we can grab hold of and move now are also very important. So in this qualitative data, and I'll show in a minute just some sample quotes of the themes that emerged around actionable drivers, were around awareness of stigma. So what we saw and what we know from our work in HIV also is that we all stigmatize on a daily basis in the language we use in our actions, and most often it's unconscious. We don't intend to harm, but we don't know that we're doing it. And so one of the drivers that we can get a hold of when we're trying to intervene on stigma is just creating awareness of what stigma is and what it does. And we saw some of this in our data where, and I'll talk a little bit more about that in a minute. Fear, there is still fear of contagion, of cancer spreading in ways that it cannot spread. So it's as an infectious disease that can happen through sharing space, basically. This came out pretty clearly in both the qualitative and quantitative data. And then our value-based judgments, our shaming and blaming of people that we do, and particularly I think with disease stigma, wanting to blame someone for why they have this condition, and related to that, sort of how that came out in our data was really around the themes that cancer is contagious, that it's a punishment, the punishment for either sins in this life or a past life, and that it's always a death sentence. And so there's stigma around death, there's stigma around what is considered untimely or death. And so these were sort of the drivers that came out in our data. And then we had different types of stigma and manifestations. So we know that we need to think about measurement and responding to the different types of stigma, whether it's internalized stigma, experienced stigma, perceived stigma, and also in a secondary stigma. So in our case, there were a lot of fears around what would happen to particularly daughters who were of marriageable age if their mother or father had cancer. They would no longer become good candidates for marriage. And so how all of this then feeds into the cancer control continuum, which we've already heard about, obviously those ultimate health outcomes. So our thinking around this, really trying to think about this data with an eye towards what can we do about cancer stigma. So with that, I'm just going to share some of these. I'm not going to read all of these, but these are sort of the themes that came out and some of the quotes behind them. So, and then a little bit of the data, the survey data, but I do want to caution that survey data is on a very small sample. So cancer is contagious. That was the clear theme. And in our survey, 25% of patients reported that someone had actually expressed their concern that they were going to contract cancer from them. Cancer as punishment. So they will say that it is the reaction of their bad deeds. They will say it is the result of their previous bad deeds. So either your bad deeds in your current life or your bad deeds in your past life. And this really leading, we don't have the data to show this, but it was linked in a discussion around this, leading to these feelings of shame. And we saw in our and also wanting to hide or not disclose, that 30% of patients that HIV field can ask that people think they're doing the right thing and they're actually stigmatizing. So we saw a lot of things about we never stigmatize our family member who's living with cancer, but we make sure that all the dishes and all the clothes and that they sleep in this are separate and that they sleep in a separate room, but no, we don't stigmatize. And so being able to break that disconnect between intention and action, and then of course the belief that cancer means certain death. So we saw again some of that presented already from Malawi. So we had lots of different stigma manifestations that came up. These were mixed with support. So there was this theme of stigma happening, but then also this strong theme of support. So as we think about stigma reduction interventions, really thinking about how we build on the positive. So and then the impact on the actual care continuum. So detection, treatment, we saw diagnosis, and then disclosure management as a big part of what came out. So just to end, I think we know it's important to do. I think there's a lot we can build on that has already been done on stigma around other medical conditions. Measurement has already been discussed. I think moving quickly to interventions is important. Communities as partners, thinking about intersectionality as a guiding framework, and thinking about multi-level and multi-sectoral studies and interventions. Again, thank you for having me here, and I'm so looking forward to learning from everybody.
Many thanks, Laura. Any questions for Laura, please put them in the chat. As I had already mentioned, we'll collect all the questions at the end of the session. So with that, I want to introduce our next speaker, Ms. Benda Kitaka. So she's from Kenya. So Ms. Kitaka is the executive director of Kilele Health Association. It's a nonprofit that equips patients, survivors, and caregivers to use lived experiences as tools for advocacy. Benda's talk is titled Cancer Stigma in Kenya, Lessons, Gaps, and Opportunities from Kilele Health. So with that, go ahead, Benda.
Thank you so much, Dr. Vidya, and I'm delighted to be here, presenting to all of us and also learning together with all of us. I'm delighted that you invited me to present about our small research that we did on cancer stigma in Kenya, and some of the lessons that we've learned, as well as the gaps that exist and opportunities that we can all work towards in bridging the gap on stigma. I would like to first acknowledge the Mount Kenya University, who are our partners in this research. This research has happened this year. We're still analyzing the data and will be publishing the same in various journals and publications. So to kick us off, I would like to just mention that Kilele Health stands for Kilele, the word in Swahili, which means to reach the top or to reach your peak. And we work to empower communities to reach the ultimate health goals by advocating for survivorship as a link to prevention. I hear when you show pictures in a meeting, people pay more attention. So that's one picture that's taken from one of our activities where we climb mountains. We climb Mount Kenya every year with survivors to showcase that there is life beyond a cancer diagnosis. The Kilele model, which I'm going to be speaking about today, and why this research is pegged on three things, all of them with the bedrock being survivorship as a link to prevention. The first one is that we challenge perceptions. We're looking at inspiring communities to realize that cancer survivors are not really beyond living, they are actually living and thriving. And that's why we climb Mount Kenya, to challenge people that if somebody can reach to the top of the mountain and they've gone through a life-debilitating disease, what about them? We also challenge beliefs, and working with various other bodies in the NCD community, we challenge beliefs that diseases cannot be survived, non-communicable diseases cannot be survived. And here we teach skills in storytelling so that people are able to get knowledge and skills to use their lived experiences as impactful stories for change. And lastly, we challenge action by providing access to either interventions or opportunities for prevention, including cervical cancer, which is the one cancer that gives us time and also gives us opportunities to prevent. So the study that I'm going to present today was done, we did a data collection in March, and we've been working on data analysis. It's an ERC and IRB approved study, and the study period is between July 2021 to January 2023. It's a pilot study, very small sample size of 42 cancer survivors, and this was done in Kenya. The research was primarily to find out what beliefs, knowledge, and attitudes and perceptions do we have on cancer and cancer stigma, and how does that affect the quality of life of cancer survivors? The whole background for that was we wanted to address the question of quality of life in survivorship and to engage our survivors with empowerment, knowledge, and skills, then they can be able to use this in the community. And of course, to look at barriers that would cause issues in survivorship and in attaining the highest optimal quality of life, but also to build a robust evidence base against which we as the cancer community can be able to use for policy advocacy. As I've mentioned, the study area was in Kenya. We were interviewing cancer survivors who have either completed treatment or are still in treatment, but have gone through most of their treatment journey. At the same time, above the age of 18, and either within the Kilele Health cohorts 2020 and 2021 of survivors who have climbed Mount Kenya, or survivors who are already in support groups, because that was an easier way to find them during the COVID-19 period. We excluded any caregivers who are not cancer survivors and anyone below the age of 18. And also for compliance purposes, we excluded people who were not willing to sign the consent form. And this we did through a cross-sectional study where we looked at both key informant interviews, but also had open-ended questions that also delved into a bit of the attitudes and knowledge that they have on stigma and survivorship. We did a pre-test of the tool that we were using so that we were able to check for feedback, check for the questions, whether they were easily understood, and then we were able to incorporate the feedback before we did the work. Some of the things that we tracked were demographics. We also looked at the cancer survivorship journey and the issues that are faced in survivorship, as well as utilizing the cancer stigma scale, which is a global tool. We adapted it to ensure that we can have data that can start us off as a pilot, and we're able to continuously monitor and see what changes happen within our program as we continue to talk about cancer and survivorship. Some of the limitations for us were budgetary. We didn't have much of a budget. Supported by Mount Kenya University with just $1,000 US. This is the study that we did, and I'm going to take you through it. So to start us off, we interviewed both male and female survivors. Majority were women, cancer survivors, and majority described themselves as cancer survivors, but some also mentioned that they were surviving, but also being caregivers to other people. And at the same time, some of them say they were survivors, but they feel like they're still patients because they have to continuously go to the hospital. The type of cancer survived, we did not exclude any type of cancer. And as is standard in Kenya, majority were breast cancer survivors. Some of them were cervical cancer survivors. And we had all the other cancers represented, which are on the screen. Some of them of note is cancers that are never talked about. For example, anal cancer, which already comes with its own type of stigma, where somebody would feel that this is a body part that they would not want to talk about. In terms of survivorship, 81% mentioned that they had survived up to the 10-year point. That is between 0 to 10 years of survivorship. And this is also very representative of cancer in Kenya, where we have about 42,000 new cases every year and about 28,000 people dying of cancer every year. So we have very low survival rates. Secondly, in terms of how cancer has interfered with their life, in terms of their survivorship journey, we found that cancer affects all spheres of life, be it the social, be it the family, be it the work environment. We also found that in terms of the highest effect and the highest challenge faced during cancer journey is financial constraint. And this also speaks into what Laura has presented about India, where we find that financial challenges, lack of finances to go through treatment, or even stoppage of treatment because of cancer is one of the things that happens in survivorship in cancer. And when we delved deeper into what are the challenges faced, we found that after receiving the news about cancer, some of them felt that this was a death sentence, or they felt devastated and lost, or even in shock and disbelief. And this did affect how then they sought treatment for cancer. Just to read one, just being told that my results read I had cancer was devastating. I saw death because I knew I would not get finance to get treatment. My mom had been diagnosed the previous year. We had a Harambee, which means crowdsourcing, and conducted on her behalf. So I stood no chance. That's the kind of fatality that comes with a cancer diagnosis. I will not read the next one because it speaks into the same challenges of loss of independence, or a lot of pain received, or why has God forsaken the person who is going through the cancer journey. And then when we ask what attitudes people have towards survivorship, towards cancer, it was mentioned that majority of people felt people see cancer as a death sentence. And you can see very high ratings on all the negative perceptions that come with a cancer diagnosis. Then we asked how then cancer survivors are viewed in the community. Again, and you can see stigma where it's represented in terms of people being seen as either disabled or vulnerable or not whole in terms of having gone through cancer. Some even mentioned that they felt society looked at them as if they were bewitched. And when we asked what they think drives this perception towards cancer, it was mentioned that majority, actually 100% felt that it's lack of information and misconceptions, misinformation, ignorance, and the fear of death. All these point to the lack of information about cancer, which then leads to stigma in the community. Lastly, we use the CAS to evaluate how severe stigma is in the community in terms of awkwardness, how comfortable people feel around people with cancer. And I want to remind all of us that when we use this CAS rating system, we used it on cancer survivors themselves. So for example, when you talk about avoidance, how uncomfortable one feels around people with cancer, it would be bound to be that we found that they do not feel as awkward amongst themselves being amongst people with cancer because they've gone through the disease. They do not feel that they can avoid their other members of the community because for them, they've gotten used to the cancer journey. They also felt that there is a bit of impact on their journey, even amongst the cancer community themselves. And they felt that people should not be held responsible for getting cancer because it's not something that somebody can hold upon themselves. But in terms of evaluating what they think the government or what the political system could do about cancer, it was evident that everybody in the study, majority of the people in the study felt that the government has a role to play and the policy framework can be further improved to better improve on cancer care in Kenya. And when we asked what measures they think can be done to combat stigma in the community or to improve cancer perception in the community, you can see from the study that we found awareness raising, using information amongst themselves that they already have, or getting to the community, advocating and lobbying. All these are things that can help to improve understanding of cancer and remove the stigma in the community. Lastly, I want to present about the perceptions of what we found out from the research and what we feel would be the next steps. There is this perception of fatality with cancer, which can be reduced and may be improved on through showcasing the survivors as thriving and living, and also utilizing their lived experiences to destigmatize, to remove stigma, to inform more, to encourage, and to even get people towards prevention. And we recommend that this pilot study acts as a baseline against which we can further investigate the stigma in the community so that we are better able to find out if indeed, if this is amongst the cancer community, what about the general population? If this is amongst the cancer community, how deeply rooted is cancer survivorship stigma in the community? And what are the things that we can be able to do to destigmatize and to encourage more people to prevent? I want to stop there so that we can be able to have more presentations. Thank you.
Thanks, Brenda. Fantastic work. And again, looking forward to hear more, listening to more about the projects as we gather questions. Our next speaker is Dr. Andrew Wood. Dr. Wood is an assistant professor of counseling at the University of Cincinnati in Ohio. His talk is on prostate cancer stigma, perspectives of self, social, and complex-based stigma. Andrew, if you want us to share your slides, please let us know. Otherwise, go ahead, please.
I can go ahead and share here. Okay, here we go. Hi, everyone. My name is Andrew Wood. I'm very happy to be here. It's such an honor to be in this very specific area of research and researchers that I've been caring about for quite a long time. So yeah, we could be talking about prostate cancer today, kind of understanding where we've been, where we're going with this research, and talking about some of the work that I've been doing over here in Cincinnati. So yeah, so where have we been with prostate cancer research? It's not one of the more well-researched. So like, cancer stigma is not the most well-researched concept. And then within that, prostate cancer tends to have a little bit less research devoted to it when we compare it to things like lung cancer. For context here, I'm talking about my research kind of existing within the United States largely. So, within our kind of survivorship numbers, prostate cancer, we have a lot longer survivorship than a lot of other cancers. And so maybe this idea of stigma does not have as much weight due to the potential mortality that some other cancers face. But when you look at stigma, there's, I think, a lot of possibility for the existence of stigma for our folks that are in their 50s, 60s, 70s on into their 80s. When we look at things like how masculinity is defined within a cultural context here in the United States. So some of the rationale for looking at prostate cancer stigma kind of exists within the nature of disease and its treatment. So this is a very intimate related disease of reproduction, sex, of romantic relationships, and how someone's body image and identity are kind of made up depending on how kind of closely you identify with some traditional masculine norms, which we'll talk about a little bit later. And when I talk about prostate cancer in men, I'm largely speaking for the majority of folks who've been diagnosed with prostate cancer, identifying as men. There's a large area of research that we need to also delve into. We look at trans-identifying individuals that have prostate cancer as an area of future research, but I'll be using the term men just for clarity's purpose with the majority of people that we work with. So men in this age group tend to be in committed relationships. And so this has led some folks to kind of identify prostate cancer as being a couple's disease. So not just affecting that individual, but also the person that will often provide care or the person who is just around that individual who's been experiencing this cancer from the diagnosis to their treatment and survivorship. So lots of work within this area of diagnosis to treatment, dealing with shame, embarrassment around things like impotence, for example, or incontinence, when we look at prostate cancer stigma. And the large majority are in committed relationships at this point. This study, I think it was around 75% of their database were in longstanding committed relationships. Yeah, so also with prostate cancer, because we have this larger kind of survivorship, I think our 5-year survivorship is around 99% right now. We have a lot of people kind of continuing on with the disease throughout the rest of their life. So that's kind of the rationale for looking at some prostate cancer, because it does have this intimate nature. That's the reason I got interested in it, of understanding men's health a bit more, and how we can work to better increase quality of life for people in survivorship. So some of the earlier investigations in prostate cancer stigma started around 2000 with some nice qualitative research. And then we got into some more quantitative research in about 2009 with Elsquest's Locante, Schiller, and Hyde's article. But within all of these earlier studies, stigma was kind of on the periphery. It was one of the interesting findings that came up. Elsquest et al. Looked at shame, blame, and stigma for those with breast, lung, and prostate cancer. And that was kind of our first quantitative foray into prostate cancer stigma research. And we're finding there is that stigma is felt by those with prostate cancer, but not to the same kind of degrees that those with breast and lung cancer experienced. So these are kind of the earlier ideas. Luckily now with our current research efforts, Larkin et al. Published a nice review of prostate cancer research earlier this year that kind of gets us up to speed with measurement, with some of the effects and some of the predictors of stigma as well. So typically we have these lower levels of stigma compared to lung and breast cancers, other cancer sites. Largely the stigma measurement that's been used, it turns out it wasn't just me that used Fife and Wright social impact scale. It turns out lots of other people have used it. And so we're seeing experiences of internalized shame, social rejection, social isolation, and financial insecurities, which are part or subscales of that social impact scale, which was normed on folks with cancer and HIV, cancer or HIV. We're finding in Larkin's article as well is this prostate cancer stigma is influenced by different conceptualizations of masculinity, intersectional cultural concerns. As we look at prostate cancer health disparities in the US, we see that Black and African American men tend to be have the highest incidence rates and highest mortality rates compared to any other race in pretty great numbers. And so when we're looking at some of the mental health aspects of cancer and their experiences, we want to be looking at the cultural aspects as well, which kind of we'll talk about in a little bit. But social support, I come from the mental health field, mental health counseling, and so social support is always one of these big predictors we want to look at. And so we're seeing that stigma is also influenced by social support within these previous reviews that we've seen. Also, stigma does have an impact on quality of life, shame, self-blame, and those sorts of areas within this prostate cancer population. So also where we're at with our current research is we have a lack of prostate cancer specific stigma measurement to my knowledge. So a lot of our research requires adaptation. I think the CAS has just mentioned in the last great presentation. And so Marlon Wardle's work here, I was in communication with them about adaptation towards one of my more current studies, which is that prostate cancer and testicular cancer social stigma, and got permission to kind of change some of the ends of the items to more specifically apply to different types of cancer. And so we don't, from my knowledge, have prostate cancer specific stigma measurement. We are also kind of at a lack of health disparities focused research within stigma, specifically in prostate cancer. Again, like we're a relatively small area of research, and within that, the health disparities it is a necessity to do research there. Is currently kind of lacking completely right now. So we want to understand some of these cultural differences and predictors and experience of stigma as well within our future research. So going into some of the research that I've been involved in, we wanted to kind of explore just some of the basics around prostate cancer, stigma, and quality of life for those who were living with prostate cancer. So this involved, this is part of my dissertation research a while ago, where I was just going to different cancer centers, providing surveys to folks and talking with them, end up talking with them throughout their doctor's appointments and everything. So even though this is a quantitative research, I still got a lot of qualitative experience out of it, which is very nice and, hugely beneficial for my understanding and my passion for this area too. So we have a moderate influence on quality of life from prostate cancer stigma, specifically within these areas of financial insecurity and social isolation being our significant predictors. As you can see here, both of these are negative predictors. So as these increase, as stigma increases, quality of life goes down. Quality of measurement in here was the functional assessment of cancer therapy, the FACT-P for prostate cancer. And in the next study, use a FACT-GP for the general population as well. We'll talk about that in a second. But social rejection, internalized shame were not as strong predictors of a negative influence on quality of life. So one of the things I became really interested in as I moved forward in my studies was looking at the couple's experience in cancer. So as I mentioned before, I think Cooper identifies prostate cancer as a couple's disease, just due to parts of the intimate nature, the relationships people tend to be in at this time in their life. So it affects both the partners within this relationship. So within the study, we looked at the influence of stigma on quality of life and relationship satisfaction. So this is a dyadic study. We had about 80 couples altogether, 81 maybe. And we looked at kind of like the shared influence of stigma as felt by the prostate cancer survivor on the couple's quality of life and the couple's relationship satisfaction. So if you've done some data analysis, or if you've read a lot, you might be familiar with the actor-partner interdependence model. This is a different model called the common fate model that's used a little bit less often, but I think theoretically, if you look at the impact of stigma on a unit, like a family or a couple, I think Park did a nice review of family stigma. Stigma impacting a couple, we kind of want to see what the outcomes of that experience of stigma looks like on that couple. So this is why we use the common fate model. And what we found within the study is we have a significant negative influence on quality of life for both partners, but not a significant influence on relationship satisfaction. Also within the study, we're finding that's more of a self-stigma, internalized stigma is a kind of better predictor of these negative outcomes too. So this was a really neat study to kind of look forward to see how couples experience stigma and what we can do to better serve them looking to the future. Where we're at now is kind of taking a step back a little bit to look at the social or the public stigma that people espouse surrounding prostate cancer. So this is a study utilizing a general population sample from Amazon and Turk, where we are looking at the public kind of perception of prostate and testicular cancer stigma. We're breaking these out into two separate sections. So luckily, we were able to find some nice scales looking at prostate cancer knowledge, looking at testicular cancer knowledge, utilizing that CAS to adapt it to stigma around prostate cancer, stigma around testicular cancer, and look at some predictors of these public perceptions. So based off the previous research, we wanted to look at some cultural factors. So part of that would include masculinity ideas, these ideas around disease attribution, how much someone is to blame for their disease, fear around cancer, and then knowledge. We know a lot of the stigma reduction efforts, whether it's mental health or HIV or cancer stigma to some extent, have looked at people's knowledge, increasing knowledge as a way to reduce stigma. So we wanted to see how this knowledge kind of influenced stigma. So what we did find is that knowledge has a negative influence on stigma. So as knowledge increases, stigma goes down. And vice versa, as knowledge goes down, stigma goes up within the general population here. Also, traditional masculine norms has a positive influence on stigma. So the more someone adheres to more traditional masculine norms, which we might consider like a toxic masculinity today, there's a direct relationship between espousing traditional masculine norms and prostate cancer stigma. This also helps true for testicular cancer stigma and also applied across gender within our sample too. So regardless of the gender of the individual, holding on to these more traditional masculine norms predicted more stigma. Disease attribution as well, which is something we expected to find, has a direct a positive relationship as well. So as someone believes someone is more at blame for their disease, more likely they're to be stigmatizing of that disease, that person as well. And part of this was based off of this idea that we saw within Vogel's research around mental health stigma, that the social stigma becomes internalized over time. So if we're looking at not only doing the intervention around self-stigma that's experienced by prostate cancer survivors, also looking at some of the prevention areas of how we can look at stigma reduction efforts and trying to kind of attack those both at the same time in order to lessen the impact of stigma on the quality of life of those experiencing prostate cancer. So not only the survivor, but also their partners too. So where are we going from here? I think one of the bigger areas to go into within prostate cancer stigma research is really looking at some of the health outcomes, how this predicts health behaviors. And I think, we look at like lung cancer, how lung cancer stigma predicts time to screening and stuff like that. I think we need some similar types of research in this area for prostate cancer. And looking also some of those treatment outcomes, how stigma might be a moderating factor and things like that. Health disparities in culture are key areas we want to look at. And understanding some of the cultural values around masculinity, around cancer and disease, and also intimacy as well. And this is where we're kind of taking this newer area of research, is looking at intimacy within Black and African American couples experiencing prostate cancer and understanding some of the stigma factors in there too. And then some of our larger maybe advocacy efforts can look at broadening an idea of masculinity so that a conceptualization of masculinity isn't stopping someone from, or is not playing as much of a role in stigmatizing those with prostate cancer. So looking at some feminist approaches like relational cultural theory to kind of influence some of the prevention efforts we have there. And that's all I have. Here's my name and my email address and my references. Thank you so much for this time. I greatly appreciate this honor.
Many thanks, Dr. Wood. That was fantastic. And I think you are receiving a lot of questions and feedback again from our audience here. So with that, I wanted to go to our next panelist. Unfortunately, our next panelist, Dr. Dylan Dritz, is not able to join us in person, but she has recorded her conversation. Dr. Dylan Dritz is a pediatric oncologist and assistant professor at St. Jude's Children's Research Hospital. She's one of our stigma grantees from our global cancer stigma supplements. And her title of her talk is Impact of Cancer Stigma cancer decision making for pediatric cancers with osteosarcoma and retinoblastoma in Guatemala, Jordan, and Zimbabwe. So, Mark, if I can have this Dylan's talk, please. Thank you.
Hi, everyone. My name is Dylan Gratz. I'm so sorry I can't be there with you virtually and live. This week is actually the International Society for Pediatric Oncology conference, and we are in person for the first time in 2 years. So I am in Barcelona, Spain, attending that conference, but I'm really grateful for this opportunity to present a little bit about stigma in pediatric cancer and the project that we're conducting. And so I'm grateful that I had the opportunity to record this presentation ahead of time, and hopefully we can all be in touch. I look forward to watching the rest of the workshop and to connecting with you all at a later date. Again, my name is Dylan Gratz. I'm an assistant professor at St. Jude Children's Research Hospital in our Department of Global Pediatric Medicine. And I'm the director of a program based around culture and communication. And this particular work focuses on stigma and the impact of stigma on cancer care decision-making among pediatric cancer patients. And for this study, we've specifically chosen to focus on patients with osteosarcoma and retinoblastoma. This study we're conducting in Zimbabwe, Guatemala, and Jordan. So as I do not have to tell this audience, stigma is a barrier to healthcare acceptance worldwide in patients with a variety of diverse conditions. And while they're still limited and there's much more to be done, there is some investigation in adult oncology, specifically, again, this is not the audience I need to tell this to, but specifically measuring stigma both in patients and non-patients, as well as the psychosocial impacts of stigma on patients and survivors. And I know you're all experts on that, but there really are not very many studies at all looking at stigma in pediatric oncology. And in fact, the existing studies are on childhood cancer survivors, and they're all thus far have been conducted in high-income countries. Meanwhile, we know that over 90% of children with cancer live in low and middle income countries. And we know sort of anecdotally and through literature that isn't specifically focused on stigma, that stigma is a barrier to pediatric cancer care globally. Some of the literature that gets at this, in South America, there's been some literature around fatalistic cancer beliefs. So the idea that cancer is synonymous with death and stigmatization of the word cancer itself. There is some data coming out of countries in the Middle East talking about how stigma may cause families to resist information, and some of this data is specifically out of Iran. There's also some data out of sub-Saharan Africa talking about how stigma might contribute to community isolation and discrimination. And this seems to be particularly prevalent among mothers of children with cancer. And we know sort of globally from practitioners globally that stigma does affect quality of care and may contribute to treatment abandonment, which is a huge cause of morbidity and mortality for pediatric cancer patients worldwide. In fact, abandonment is one of the leading causes of death in low and middle income countries. And abandonment is just defined as either upfront refusal of care or 4 consecutive weeks without therapy. Thus far, however, like I said, none of these studies have specifically focused on stigma, and all studies have been done at a local, mostly single center level. There are no studies formally exploring the impact of stigma on pediatric cancer care acceptance or adherence. So the aims of our study were to explore the ways in which stigma influences decision-making in cancer care acceptance in Guatemala, Jordan, and Zimbabwe, as well as to identify potential strategies and opportunities to mitigate stigma during cancer treatment decision-making. And we've chosen to focus on retinoblastoma and osteosarcoma because we know there are high rates of abandonment in these patient populations. And there are extra elements, including appearance-altering surgery, that are part of the treatment of these diagnoses. So often amputation or enucleation is part of therapy. And this also allows us to explore diseases with different survival rates and different patient populations. So retinoblastoma is predominantly a disease of very young children, infants, and usually has a very good survival rate, whereas osteosarcoma tends to affect adolescents and globally has a very poor survival rate. For this study, we've adapted a theoretical model, so the framework for health stigma and discrimination, which can be applied globally but is not unique to cancer care. It was intentionally developed to be broad and apply to various disease types and in global settings. The work that went into developing this framework was focused on adult populations. And so we have adapted it, and we actually added 6 factors that were previously found to impact stigma as what we believe will be potential drivers and or facilitators. And so you can see here that some of this model looks at some of the things that contribute to stigma marking, and then later stigma experiences and stigma practices within different cultures. So we are conducting this as a qualitative study at 3 institutions: Unidad Nacional Oncología Pediátrica in Guatemala, King Hussein Cancer Center in Jordan, and Parientoa Hospital in Zimbabwe. These are geographically, socioeconomically, and culturally diverse settings, and all 3 are big cancer centers with the necessary populations to reach accrual and interested and engaged teams. We are including both adolescents, parents, and healthcare professionals in this study. So more specifically, the participant population includes parents of children with recently diagnosed osteosarcoma or retinoblastoma, defined as within the last 8 weeks, adolescents with osteosarcoma, and we have selected adolescents whose parents we're also including, and then a variety of healthcare providers, so oncologists, ophthalmologists, surgeons, radiation oncologists, psychosocial providers, anyone involved in the care of these children. And sorry, I think I said within 8 weeks, but you'll see right there, it's within 12 weeks of diagnosis. I misspoke. So the study design, these are semi-structured interviews around that framework I discussed, and focused both on those drivers and experiences. And then additionally, we asked questions about strategies for overcoming stigma. And in addition to the qualitative work, we're pilot testing 2 tools that have been validated in adult cancer populations, which you'll see listed there. To date, these are the interviews we've conducted. So almost 20 interviews with parents, a handful of interviews with patients, and then another 18 with a variety of providers. I'm going to present some of the emerging data. I'd like to just note that this is very early work. We're sort of still wrapping up data collection and beginning analysis. So there's lots left to be done, but this is a taste of what's to come. So we are identifying some common drivers across institutions. Patients have said that the word cancer itself can be stigmatizing, that things like hair loss, side effects of therapy contribute to stigma, as well as fear that the disease is contagious. Parents talk about misconceptions and especially mention things like witchcraft or being cursed. They also talk about the physical stigmata, so not just hair loss, but enucleation and amputation. The financial burden weighs heavily on parents and contributes to stigma, as stigma has been associated with poverty. And then lack of education or ignorance from the community contributing to stigma. The clinicians talk about many of the same factors, but in addition identify lack of psychosocial support, certain treatment modalities. So in Zimbabwe, we've seen that radiation therapy carries a lot of stigma. And then they talk not just about the physical stigmata, but also the disability that results from some of the treatment. For instance, blindness if you have a bilateral enucleation. In terms of facilitators, things that could potentially mitigate stigma, everyone talks about the use of prosthetics, specifically if there's funding provided for these prosthetic devices. Support groups or counseling, as well as meeting survivors, other folks who have been through this, was thought to be helpful across the board. Encouragement from family, community, or the healthcare team was something that the patients specifically talk about, and they talk about positivity or optimism, how being surrounded by positivity and optimism helps. Parents talk about education or awareness campaigns that could be done in the community, and also emphasize how important it is to feel loved and supported. And clinicians specifically talk about audiovisual aids as part of education or awareness campaigns, and how important it is to have a multidisciplinary team to help provide diagnostic information and counsel. In terms of the experience, patients talk about the emotions that they feel: sadness, fear, wondering why them. They worry about the future. They talk about restrictions on activities they used to enjoy, like going shopping or visiting family, and that sometimes the stigma leads to self-isolation, so they themselves don't want to go out. Parents talk about being concerned their children are internalizing the stigma they experience and worrying how it'll affect them in the future. They talked about their children being excluded from community and sometimes the whole family being excluded from the community, and how this can lead to depression and anxiety. Clinicians also notice children being isolated or excluded both in the community and at school. There are references to mothers being abandoned by their husbands. They also talked about depression and a lack of independence, particularly among adolescents. And then some of the practices that were observed in the community. So again, being made fun of at school, discrimination in hiring, particularly for adolescents who have entered the workforce or thinking about that going forward, and being left behind on family outings. So not intentional, but especially after an amputation, if a patient can't, for instance, walk stairs or walk for long distances, they may be left behind. Parents talked about worrying about their children being bullied and experiencing gossip within the community, and that a family may be looked down upon. And clinicians talked about this idea that a family or a child might not be whole, especially after something like an amputation or an enucleation. They talked about children being excluded from activities at school, and that a lot of families don't discuss or disclose the diagnosis to the community because they don't feel safe and may stay at home or keep the child at home because of that fear. So many of our participants talked about how this is affecting outcomes, particularly the clinicians referenced abandonment. They referenced delays in care, saying that that in turn leads to worsening disease and then increased stigma from the physical stigmata of that worsening disease. So it creates a terrible cycle. Patients are seeking out alternative medicine or other options, second opinions, or refusing surgery because of stigma. But there was some discussion of strength, encouragement, and resilience that comes with a cancer diagnosis and how this can work to counter stigma. So this is just the beginning. We're just starting to define what pediatric oncology clinicians around the world have maybe always known, just providing this care. And by that, I mean, we're really starting to spell out what stigma looks like, how it impacts care, and starting to think about how we can prevent it. And so our next steps, we hope to develop a stigma assessment tool for pediatric cancer and begin work on interventions to mitigate stigma and its impact. I present this work on behalf of a very large team. Here are some of the important members of that team. And of course, we're grateful for the funding from the National Cancer Institute. I've included some selected references. And again, I'd be happy to connect in the future, and I'm really grateful for this opportunity. Thank you all. I hope you have a wonderful workshop.
So if I can have all of, thanks, if I can have all of the speakers turn on their camera,
Kind
please.
invitation to present at this important meeting.
If I can have Brenda and Laura turn on their cameras, please. We have a few questions from our audience. And again, to everyone listening, feel free to use the raise hand feature if you have a question that you want to be addressed directly. I am collating all the questions and I'll try and triage it to the best possible way. And again, if I miss something, feel free to flag me or use the raise hand feature. So one question, and I think it's a recurring theme for us is, about this idea which Prajakta Atsul had raised in the chat, is about this idea of how stigma is measured. So often most of the stigma measurement occurs around, either the patients or the immediate caregivers, family providers, etc. But what I think one of the things that lack, and in fact, I know of only one study which talks about cancer stigma in the general population, how stigma perceived, what are some of the measurements to understand and think of stigma, because that really speaks to a lot of the misinformation that occurs in the community, in the societies. So if I can have maybe 2 minutes per speaker to address this, and then I see Bill has his hand raised, so we'll go to Bill next. Thank you. Laura, do you want to kick us off?
Sure, thanks. And I saw that comment. I think it's a really important point. And I think as we also think towards interventions, often because our measurement is focused at the person who is experiencing the stigma, we tend to put the burden of responding to stigma on the person who's experiencing it. So I think also thinking about our measurement and how we frame stigma in terms of interventions. I think, you know, like I said, I'm coming back into the cancer stigma realm. Thank you for this invitation. So I don't know the measurement really well. We do have measures in the HIV world, and we also have just completed work on deaf and hard of hearing stigma in both Ghana and the US. And I just was so struck at this last, because we collected data with parents, I was so struck at the parallels. And so one of the things I've learned, I've been working in stigma for over 25 years now, and I am more and more convinced that stigma is something that is fundamentally human and core. And so I think there's a lot we can bring from other areas where we have measured the community stigma.
Brenda,
Oops.
and then Andrew.
Okay, so in terms of tools to measure stigma, when we were looking at our tool for measuring stigma in Kenya, we actually looked at the cancer stigma scale, which we found online from a study that was done by Marlowe L.A. and Waddell J. And it's a scale developed to measure stigma in non-patient population, but we use that to measure in a patient survivor population. So those 6 elements that we were measuring are standardized, but we looked at it from a point of how do survivors perceive stigma and how do they experience stigma in the community. One of the things that we noticed from our study is that this needs to be further validated, because using the scale without other elements such as the demographics or the desk research to be able to understand the background or the environment against which we're measuring would be limiting, because we are making assumptions that the understanding of, for example, avoidance would be the same in low and middle income countries as compared to the high income countries where this study was conducted. So one of the things we're recommending is that we as the research community are deliberate about measuring stigma both in the cancer community as well as general population, and at the same time looking at other specialized communities such as the healthcare worker, because they have also an impact on how cancer is perceived and how early detection is uptaken in the community. Thank you.
Thanks, Brenda. Andrew, did you have anything to add to that?
Yeah, I think that, you know, in my research and trying to find a cancer stigma scale at the time I was doing that more specific patient-centered research was like, I just found the closest thing I found was a stigma scale that was normed partially on cancer patients. And I think looking towards like some initiatives around quality of life measurement, like the fact, like looking at like, what is it, EQ5D and stuff like that that's out there, and kind of like having a similar framework around cancer stigma, since we're having different sites having kind of different considerations, and like the fact has different iterations based off of type of cancer. I think that would be like a neat way to go into. It would take a ton of work and a ton of money to do that. But you know, that's why we're here to talk about some of these ideas and generate that. And yeah, I think like the CAS is like a nice tool. I've done some like correspondence with Marlowe to kind of see like how can we use this best, and they're very open to adaptation, but it does need to have that cultural context to it, which I think looking at like the EQ5D and how they go about translations or other quality of life measures and how they go about that translation and cultural context to adapt those measures is really important in this process as well. So even though we have a couple ones that will work, I think we need to get a little bit more granular to better understand different types of cancers and different types of cancers in different places.
Great, thanks, Andrew. Bill, did you want to?
Sure. Hi, everybody. Bill Klein from NCI, and thanks for a terrific set of presentations. One thing that strikes me in listening to them, and this is something I've seen in literature before, but just very clear in hearing these talks, is the difference between stigma directed at the patient and stigma directed at the patient's family or other group that the patient might belong to. And I think that's a really interesting difference that we don't really appreciate in Western research, industrialized countries where individuals are thought to be responsible for their outcomes. and they're somewhat separated from families. When you deal with more collectivistic countries and cultures, there's a sense that individuals are part of their community, and their community shares some of the experience that they are experiencing. And so my question is, what does that mean in terms of measurement and other kinds of issues in this literature? We can't just measure the perception of stigma on the part of the patient, for example. We need to measure how the family feels, particularly if cancer is viewed as contagious, right? Because that's going to make the family feel targeted even more. What are the implications for the kind of research that has to be done if we think about stigma as a collectivist problem as opposed to an individualistic problem?
Laura, I see that you've unmuted, so please go ahead.
Okay, go ahead. Thanks, Bill, for that point. And I think not just in cancer, but in other areas, that's very important. And there's lots of different terms for, we talk in the HIV field about secondary stigma. So the stigma that is experienced or perceived or internalized by someone who's close to the person who has the condition or is part of a group. And so I think it's really important, and it definitely affects care and also sort of the resilience and being able to. So we do have validated, I want to say, do we have I know we just validated measures for secondary stigma among parents of children who are deaf and hard of hearing, and also among caregivers of older people who are deaf or hard of hearing. And so we do have measures, and I think it is very important because it definitely affects care, and it affects also the person who's the direct recipient of the I guess the primary stigma would be the way to say it, the support they get, and also the concealment. So we're finding that particularly in our study in India, families were very much about concealing because particularly in the Indian context, if they had daughters or sons who were about ready to get married, the fact that there was a cancer diagnosis in the family would affect their children's marital prospect. So yes, a very, very important thing. And so I think when we think about measurement, that's the thing about measurement is it's very nuanced, and there's lots of different types of stigma that we need to measure, and in different groups.
Thank you.
Thanks, Laura. Benda or Andrew, did you have anything to add? If not, we'll move to the next question.
Sure. I think my easy answer for that would be just looking at more community-based research, like looking at action research, CVPR, as methods to develop a larger understanding of what cancer is, not just, I'm really a big fan of dyadic data, so looking at the couple's experience there is one path, but to get that larger community experience, you need to have everyone kind of involved as parts of that research. By parts of research, I mean like investigators, not participants necessarily, but of having that mixed relationship, which makes the research more difficult, but also at the same time more fruitful into having a better, more thorough understanding of the cancer stigma experience from the individual out to these different levels of influence too.
So the only thing I would add to that conversation, Vidya, is if we look at the measurement of stigma, especially from our region, which is really still very green, very virgin territory for research, we need to think about why are we measuring stigma and to what end are we doing it? For example, from a practice perspective, when you're talking to people and all they see is death or disabled or all those stigmatizing words that come out from the research that we did, the one thing that keeps coming to mind is, why then would we tell them that go get screened? Towards what? To death? And it's evident even in the way that cancer diagnosis is perceived. And so from a programmatic perspective, my call to the research community is, in our region, it's still very green. Come do the research. But after you do so, think beyond the research into the next step. How do we implement the findings so that we start shifting that needle and start empowering survivors to use their lived experiences to change the curve that cancer is a death sentence right now? That's what I would add. Thank you.
Thanks, Brenda. And I think Patty Gravitt, our deputy director, had raised an important, context about the sociocultural context in which the stigma is measured and the importance of that. And I think pretty much everybody in this panel has already alluded to adapting either, the existing CAS scales or things for within their context, because it's, without the actual social context or socioeconomic, political, gender, so many other intersectional pieces to this understanding stigma, it really will not give us the entire picture of what we are measuring and how that impacts the patient or the condition. One question which I thought was very interesting, and Andrew, thanks for raising this. In your presentation, you talked about the connection to disparities and how it's not, stigma studied. Everybody knows and that the obvious connection to cancer disparities, but I don't think that connection is very well established in terms of the research pieces itself. And I was curious if our panelists can talk a little bit about how they see these pieces and some of the outcomes based on their research, how this connects to and addresses global cancer disparities. Andrew, do you want to start us off since you had raised this issue?
Sure, yeah. So in all honesty, I come from like the mental health realm, so psychosocial oncology is kind of where I'm delving into. And so in understanding the health disparities within cancer, I'm like, that stuff exists, is established. I need to understand from my expertise, my perspective, what are the mental health disparities that might exist within that. And so if you're seeing many people that look like you or similar to you or in your family that are dying from this disease, how does that affect your experience with it later on? So we think about prostate cancer and how, it can be seen as inevitable for a lot of people. There's going to be some kind of difference in how we perceive that going forward. So whether that's, and some of the research looked at quality of life disparities exist in some studies, they don't exist in other ones within prostate cancer specifically. I think, just understanding if there is a health disparity that exists, and we most likely there's going to be some attitude around that, some mental health aspect to it that we just currently don't have right now from my perspective. There's some really good research starting up, a lot of good qualitative research of looking at cultural differences and understanding diseases and different types of cancer and the couples components and stuff like that. But as far as like the more quantitative research and how we're seeing those health disparities and establishing what those look like are just kind of in the very early development stages right now. So.
Brenda and Laura, did you have anything to add to the connection piece and how your, some of the implications of outcomes of your work?
So if I can go first. When we speak about disparities, again, I keep going back to our programming and what it is that we set out to do in the first place. We had a cohort of 20 that had gone through up Mount Kenya, 22 to be specific. They had gone up Mount Kenya in 2 cohorts, and when they came down, they were literally a different set of survivors. In essence, they had created a community amongst themselves. They were more vocal about advocacy, about telling their stories for impact, about reaching out to the community. And we could see the clarity in which they were able to express themselves against the stigma that they face in the community and what they are going to start doing about it. And paired with that, then we took other members of the community, cancer community who are in support groups that have not gone through the experience of Kilele, for us to be able to see if there is a difference in how they are perceiving stigma. But it's clear from the study that the disparities are there, yes, from somebody who already has that self-understanding of why this is happening to me and how can I change the community, versus the ones who don't, who see it as it's a community against us. The question that I keep posing to all of us is, how can we then move from that understanding and to application where we empower more survivors, especially in our area where we don't have as many healthcare workers, where we don't have as many support systems for the cancer patients to be able to use their lived experiences as agents of change, both at the healthcare system, but also in the community in creating a better understanding that cancer is not death, that cancer can be survived, that interventions exist. That's how we're going to reduce disparities. Thank you.
Thanks,
That-
Ben. Go ahead.
Just
Lara.
to add quickly, and I think there's a question in the chat about intersectional stigma. And I think as we think about disparities, we do need to think about the root of the power. Stigma is all about power when it comes down to it, and it's about the social forces. Stigma isn't something that is individual, and I think we need to be careful when we talk about stigma and defining it as really being careful not to root this as something that is within the individual and that it is about an individual identity. This is a social process that involves power, which obviously gets at the root of disparities. And so I think at least in the HIV field, and if people are interested, there's a special supplement that just came out in the American Journal of Public Health around intersectional stigma that was actually NIH sponsored, obviously focused on HIV, but I think it really leads to us to really think about that. And I think in the cancer stigma field, we can learn from all, I would say, some of the challenges or maybe diversions that we took in the HIV stigma world that has makes us not where we should be 30 years into the epidemic, that we can kind of jumpstart. And I think what Benda has said about, this, we need to keep our eye on what this is about and moving very quickly to interventions. And I think that is, and in those interventions, thinking about who has access to resources, what is causing that, that is leading to these disparities.
Thanks, Laura. I had one question, which I think overarches some of the issues that were raised across the panelists, was from our colleague Mishka Sirakali. So it is about addressing stigma reduction, some suggestions from our panelists for thinking about how we take all of the data we are gathering and inform policy. What are some of the policy level decisions that can come across the national cancer control plans or different levels across the care continuum for patients to benefit from some of the research that's being done? Mishka, I think you've stumped our panel. So Benda, did you want to go first?
I could go first. I could go first. It's interesting that question resonates so much with me, because ultimately what we're doing is building a mass of action from the grassroots to be able to demand for what is rightfully the right care for patients. For example, and this is no aspersion to my government, we have very good policies in Kenya. We sit on technical meetings, we have conversations around what needs to be done, but because of the competing interests, we find that budget allocation to cancer care and control and management is often limited. Meaning then we have to rely on partners, we have to rely on funding from other bodies to come and bridge the gaps in care and control of cancer in Kenya. And that is a song for every other African country. And so from a policy perspective, Mishka, I'm glad you've asked that. It's about moving from textbook knowledge to actual application, getting our governments to invest in cancer control, cancer management, cancer care, survivorship care, and reducing the burden to the patient. For example, we keep talking about UHC, universal health coverage. If we strengthen cancer care, we are also strengthening for other NCDs. But if we don't take care of the cancer continuum, the stigma will still continue. People will still fear cancer, and therefore will still spend more in terms of treating invasive cancers as opposed to preventing cancers that are preventable. Secondly, and this is my last point so that the other speakers can also contribute, I tend to think that we need to start equipping communities to own their health. I find that we often want to point fingers at the policy, but when the policy environment is taken care of, we do not have people utilizing the services. And the reason is the disconnect between what is available and what people can make use of. We have good care, we have good hospitals, but you'll still find people wanting to do medical tourism to other countries, not understanding what is already available in the community. And that's where I see the role of survivorship as a link to prevention because the survivor has gone through the whole continuum. They've experienced the lack of information. They've gotten into the healthcare system. They've understood what is working, what is not working. They have seen what they can do themselves. They have also seen what is possible in the healthcare system. And they know the gaps that exist in financing. They know what exists in care, in control, in management. What if we were to harness that body of knowledge and utilize it to simplify oncology in the community, so that people are not seeing cancer as that big disease causing deaths, but it's something that we have control over. And so from a policy perspective, Mishka, if I was to respond briefly, let's look for ways of monetizing the experience that survivors have. Let's look for ways for fitting them in the healthcare system as community health workers and volunteers who can go back to the community to say, I survived this, so can you. And in fact, you have a better chance because I survived it. I can lead you better towards better outcomes for yourself. That's what I have to say. Thanks.
So we're almost out of time, and I wanted our next speaker is ready. So Laura, did you have a quick comment, or Andrew? If not, I wanted to close this session.
I did want to add, just to support what Binda said, that's extremely important because just as an example, I know this guy in Cincinnati where I live. He'll know more about prostate cancer than I ever will. As a 2-time survivor. And he just proselytizes. He goes to community meeting churches to talk about his experience with prostate cancer and also his experience with like medical aids to help his sexual relationship with his wife and to destigmatize this by himself. He doesn't have a ton of support, but he's out there doing it. So I think policy change is really great and everything, but if we're able to help those who have the mission in their life to do that, I think that's a really great effort to engage in and support those people.
Thanks, Andrew. And I saw that there are a couple of questions or comments about intersectionality and measurements. We have both of those topics covered in the upcoming session, so please stay tuned. And I apologize if we haven't gotten to all of your questions. We do plan to record this session. And again, feel free to reach out to us if you have additional questions or comments. Thanks, everyone, for this fantastic panel this morning and kicking us off with a thought-provoking session. So again, a big shout out and thank you to all our panelists for joining us today. Thanks.
Thank you for the opportunity.
Thank you.
So I want to, it is my absolute pleasure to introduce our plenary speaker for today, Dr. Anne Stengel. Dr. Stengel is the Senior Advisor for Elimination of Stigma and Discrimination in the Division of Global HIV and TB at CDC. She is also an Associate Faculty with Department of International Health at Johns Hopkins Bloomberg School of Public Health. Dr. Stengel has 20 plus years of international public health experience in Africa, Asia, and in the Caribbean. Her research focuses on understanding and addressing stigma, social and structural determinants of health, including intersectional stigma, which is a topic of interest to many of you, and impeding access to and uptake of health services among underserved populations globally, and is a leading expert of health-related stigma and discrimination, and has contributed to theoretical understanding of how stigmatization process operates in the context of health. Her paper on the stigma framework, a discrimination framework, is very well known and has been adapted in several studies. So with that, I hand this next mic to Anne Stengel. Thank you very much for joining us, Anne.
Thank you so much, Vidya, and it's really a pleasure to be here with everyone today. I'm just going to pull up my slides, so bear with me for a second. Okay. All right, can you see those, Vidya?
Yes,
right.
We can.
Okay, good. Just want to make sure before I dive in. So this has been quite the day. As many of you know, there's a lot of stigma meetings happening. So Laura Nyblade and myself just came from one on HIV stigma. So I'm just super excited to be here with you today. to share a bit more about the health stigma and discrimination framework. I'm going to provide a bit of an overview, and then I'm going to show an example of an application of the HSDF to cancer stigma research. So the idea for developing a cross-cutting health stigma and discrimination framework emerged in 2017 at a meeting of health stigma researchers hosted by the NIH Fogarty Center and NIMH. And I think some of you were at this meeting. Vidya, I'm looking at you. At the meeting, we discussed how researchers studying health-related stigma have tended to focus quite narrowly on a specific disease or health condition. And this approach has led to theoretical silos, despite the fact that the stigmatization process is fairly similar across health conditions and contexts. So for example, we identified 7 obesity stigma frameworks, 7 HIV stigma frameworks, and 5 mental health stigma frameworks when preparing the framework paper. In addition, health stigma frameworks tend to concentrate on psychological pathways among individuals. Few explore the social and structural pathways leading to stigma, and few include intersectional stigma. As a result, current health stigma frameworks really limit researchers' ability to inform the multi-level interventions required to meaningfully influence the stigmatization process. This siloed approach impedes comparisons across stigmatized conditions, and it also impedes research on innovations to reduce health-related stigma and improve health outcomes. So in response, we developed the Health Stigma and Discrimination Framework, which was published in early 2019. The framework builds from existing conceptualizations of health-related stigma and from practical experience of the co-authors in designing stigma reduction interventions for a range of health-related stigmas. So I just want to take a moment to acknowledge my co-authors, who you see pictured here. It was really such an honor to work with some of the world's greatest thinkers on this topic. Collectively, we brought experience from stigma research on mental health, HIV, leprosy, cancer, tuberculosis, and obesity. And I think the resulting framework really benefited from this diversity of experiences. Our intent was to provide a broad orienting framework akin to Perlin's stress process model to give conceptual organization to diverse lines of research that are underway across disciplines. So I'm going to spend several minutes on this slide in order to walk you through the process and define some of the key terminology. So the Health Stigma and Discrimination Framework articulates the stigmatization process as it unfolds across the socio-ecological spectrum in the context of health, which can vary across economic contexts in low, middle, and high income countries. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, and stigma manifestations, which influence a range of outcomes among affected populations, as well as organizations and institutions that ultimately impact health and society. So the first domain refers to factors that drive or facilitate health-related stigma. Drivers vary by health condition, but are conceptualized as inherently negative. They may range from fear of infection through casual contact for communicable diseases, to concerns about productivity due to poor health for chronic conditions, to social judgment and blame. Facilitators, however, may be positive or negative influences. So for example, the presence or absence of occupational safety standards and protective supplies in health facilities can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. Drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or other perceived difference, such as race, class, gender, sexual orientation, or occupation. Intersecting or intersectional stigma occurs when people are marked with multiple stigmas. Once a stigma is applied, it manifests in a range of stigma experiences and practices. Stigma experiences can include experienced discrimination, which refers to stigmatizing actions or omissions For example, the failure to include ramps for people with disabilities that are prohibited under international human rights law. For example, losing housing because of one's HIV status. Experienced stigma refers to stigmatizing actions that fall outside the purview of international human rights law, such as double gloving or avoiding frequenting someone's business. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with his or her stigmatized status. Perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetrated by others if their health condition becomes known, are also classified as stigma experiences in our framework. Lastly, secondary or associative stigma refers to the experience of stigma by family or friends of members of stigmatized groups, or among healthcare providers who provide care to members of stigmatized groups. Those are also included under stigma experiences. Stigma practices can include stereotypes, prejudice, stigmatizing behavior, and discriminatory attitudes. In the framework, we consider stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. We postulate that stigma manifestations go on to influence a number of outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience, or the power to challenge stigma, and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protection. While the framework is specific to health-related stigma, it recognizes that health-related stigma often co-occurs with other intersecting stigmas, such as those related to sexual orientation, gender, race, occupation, and poverty. Incorporating intersectional stigma into the framework is necessary, as stigma manifestations and health outcomes may be influenced by a range of stigmatizing circumstances that must be considered to understand the full impact of stigma. Okay, so what is different about the new framework? The health stigma and discrimination framework differs from many other models in that it does not distinguish the stigmatized from the stigmatizer. The absence of this dichotomy is intentional, as we sought to challenge the us versus them distinction that enables people to set others apart as different from the norm, which is a key component of the stigmatization process. We really sought to move away from the psychological models that see stigma as a thing which individuals impose on others, and instead emphasize the broader social, cultural, political, and economic forces that structure stigma. So removing this us versus them dichotomy also makes the framework more palatable to change agents, such as community leaders, advocates, and policymakers, as it highlights that all people can act as change agents and underscores the need for self-reflection and awareness of biases. Another difference from previous frameworks is the separation of manifestations into experiences and practices. This distinction clarifies the pathways to various outcomes following the stigma marking phase of the process. Those who experience, internalize, perceive, or anticipate health-related stigma face a range of possible outcomes, such as delayed treatment, poor adherence to treatment, or intensification of risk behavior that may diminish their health and well-being. Stigma practices, on the other hand, highlight how the stigmatization process can generate or reinforce stereotypes and prejudice towards people or groups living with or at risk of various health conditions, and foster discriminatory attitudes that fuel social inequalities. We also differentiated outcomes for affected populations from outcomes for organizations and institutions. Our framework seeks to demonstrate that stigma experiences and practices influence both affected populations and organizations and institutions, which then together affect the health and social impacts of stigma. So by articulating these outcomes, the framework highlights the need for multi-level interventions to respond to health-related stigma. It also focuses attention on the far-reaching influence of health-related stigma on societies as well as individuals. So how do we use the framework? One way is to guide the development of interventions. The framework can be used as a tool to facilitate discussion among researchers, program implementers, and policymakers. For example, key questions to discuss include: what are the drivers of specific health-related stigma and discrimination in a specific country or context? What are the facilitators? What other stigmas may intersect with the health-related stigma? How does the health-related stigma manifest? Answers to these questions can help determine whether public health practitioners, clinicians, and policymakers, or where, they should focus their efforts. So in terms of where to intervene, ideally we want to stop stigma marking from occurring. So interventions often focus on the drivers and facilitators of stigma. While we would like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. So it's our hope that the framework will enable stigma researchers across disciplines to standardize measures, compare outcomes, and build more effective cross-cutting interventions. Researchers can use the framework to generate research foci, to explore multiple health issues, and consider the intersections between multiple identities, social inequalities, and health issues. Implementation science approaches can advance how we tailor and apply the framework to guide stigma and discrimination reduction interventions and policies. So the health stigma and discrimination framework can also inform discourse and actions to address intersectional stigma. However, in order to do this, you really need to include a broad range of stakeholders in discussions about intersectional stigma, not just health experts. The stigmatization process is ubiquitous, so the framework applies regardless of whether it's a health-related stigma or an identity or social stigma that's being discussed. And the social impacts of stigma and discrimination, it's important to note, are just as important as health impacts. Therefore, addressing the intersectional stigmas that combine to create either advantages or disadvantages for people is really critical if we're to achieve both health equity and social justice. So I just wanted to take a moment to talk about some applications of the HSDF to date. So in terms of research utilization, the Health Stigma and Discrimination Framework has been cited 474 times since its publication across a variety of disciplines. In addition, many doctoral students have reached out requesting to use the framework to guide their research on various topics such as stigma of child trafficking survivors, and just last week, stigma related to sexual distress in the young adult cancer population. And this morning, I received an email from someone who's looking to use the framework related to childhood obesity stigma. The HSDF has also been included in the UNAIDS latest, in 2020, UNAIDS came out with their latest evidence to inform interventions to eliminate all forms of HIV-related stigma and discrimination, as well as a companion piece on measuring progress, which will be released later this year. And lastly, the framework has been included in at least 3 systematic reviews that I'm aware of. So I think that the framework is having the impact that we were hoping it would in providing a broad orienting framework for understanding and addressing stigma and discrimination across a range of disciplines and diseases. So now I want to come to the example of the application of the framework to cancer stigma research. Cervical cancer is the 4th most common cancer among women in the world, and about 90% of cervical cancer deaths occur in low and middle income countries. In Nepal, a few qualitative studies have suggested that stigma and discrimination associated with cervical cancer may act as a barrier to screening for cervical cancer among women of reproductive age. To date, no studies have examined cancer and STI stigma quantitatively in Nepal, and little is known about the drivers of cancer and STI stigma in this context. So to address this gap, researchers from Kathmandu University Medical School and the Yale School of Public Health are currently implementing a mixed methods study informed by the HSDF among women in Dhulikhel, Nepal. So this study has three aims. The first is to explore the drivers, facilitators, and manifestations of cervical cancer stigma at individual, family, health facility, and community levels. To accomplish this, the researchers used the HSDF to inform the development of in-depth interview guides, and interviews were then conducted with 32 women, family members, healthcare workers, and community leaders in the study area. The HSDF is also informing the analysis of the qualitative data. Second, the study aims to validate and cross-culturally adapt the cancer stigma scale. And third, the study aims to assess the association between cancer stigma and cervical cancer screening uptake. So while findings from this study are not yet available, the information learned from the in-depth interviews should be very helpful in developing interventions to prevent or mitigate cervical cancer and STI stigma. And I believe that Dr. Shweta, who is the co-PI for this NCI-funded study, is participating in the workshop and will hopefully be able to answer any questions you may have about this study. So in conclusion, the health stigma and discrimination framework can be used to develop or adapt interventions to address health-related and intersectional stigmas at multiple socioecological levels. We believe that research and interventions inspired by a common framework will enable the field to identify commonalities and differences in stigma processes across diseases and identities, and amplify our collective ability to respond effectively and at scale to this major driver of poor health and social outcomes globally. So thank you so much for your time, and I'm happy to answer any questions you have.
Great. First of all, thanks, Anne, for talking about Archana and Donna's work in Nepal. Unfortunately, because of the time difference, Archana couldn't join and talk about this their work. So I'm super happy that you mentioned it. And I think that leads to my question: is in terms of adaptations of stigma measures and using your the stigma discrimination framework, what are some of the ways in which we can be more engaged? I know that you did mention intersectionality, you did mention about some of the ways in which we can think about health systems approaches, but there's so much to unpack. And I was thinking, for a researcher, in terms of using it for cancer stigma as the primary focus and everything else, we cannot distinguish cancer stigma as its own thing, embedded in the context, sociocultural context. How would that look like, and what are some of the ways we can be more creative or expand on the existing framework for us to really understand stigma and then develop interventions that are meaningful?
Sure. Thank you for the question. So I think what I've seen so far is that sometimes people do take the framework and then they adapt it. They say, okay, I'm going to adapt this specifically to whatever type of stigma we're focusing on. And I think sometimes that can be helpful because it helps to focus the group of researchers and policymakers and community members, whoever is working on a specific stigma. It helps them to sort of focus in on specifically for their context, what are the drivers we need to be worried about? What are the facilitators? How is this manifesting? Is it more problematic for people living with the disease? Is it more problematic for duty bearers, healthcare workers, and so on? So I don't necessarily think, I don't want to discourage people from doing that adaptation. And I think, frankly, in Archana's work, I think she did, keep the framework intact, so to speak, but really specifically went through and tried to discern sort of how do we use this to inform what we're going to ask about in our in-depth interview guide. Like, how are we going to get at those drivers? How are we going to get at the facilitators? So I think it can be used in either way. I know for PrEP stigma, this is pre-exposure prophylaxis. And I think Laura's on the call, and I think one of her colleagues from RTI took the framework and adapted it to look specifically at PrEP stigma. So I've seen it done both ways. And I think, frankly, to me, however it can be helpful to people makes me happy, right? I don't think people need to just stick with it as it is. Obviously, I mean, it's meant to be this broad framework. But I've seen it used in both ways, and I think to good effect. in terms of cancer stigma, I'm just trying to think how, I mean, that so far the only example I'm aware of is Archana's study. There may be other people on the call that have that are thinking to adapt the framework, but I think that really what's helpful is it's to kind of bring people together around the table. If you've got a group of researchers or you've got community who are experiencing, you know, whichever kind of cancer related stigma, you know, to really bring people to the table, it's a really nice way to have a conversation. So it's, to me, I look at it as a tool to sort of have those initial conversations, to be forming research questions, to be trying to understand, you know, along with the community of people affected by these various cancers, you know, what is it that they're experiencing, and what are some of the challenges that are really important, or things that they need the most help with? What are some of the structural issues? Are there, you know, and the nice thing too is it helps you look across those different levels. I'm sure I missed the morning panel, apologies, but I'm sure someone talked about the need for multi-level interventions. So Archana is trying in that grant in Nepal to really work across those levels with individual women, with facilities, with community. They're really trying to think about those different levels and those different factors and how they might influence the experience of stigma, which in that case is keeping women from screening for cervical cancer. So I'll stop there. See if you have any other questions.
Yeah, no, thanks, Anne. That was great. I think so. The next question I have is from one of our audience here, and pretty much think along the lines I was thinking was, is there a repository of adapted frameworks for specific cancer types of or NCD conditions? Which I think was, I was going to ask you, is that something we can think about as we are developing, you know, effective measures to understand and use the existing frameworks, but really, you know, to expand the field, so to speak. So I think that's a fabulous idea. I was curious if you've already thought that, or what the request for that.
So it's interesting. I think because the framework's only been out since 2019, I think a lot of people have been using it, but they haven't necessarily published on it yet. These are, you know, grants are in progress, or so I'm not sure yet that, I mean, a repository, I think that's a great idea to see how people have adapted it for different contexts. There was a paper that came out recently in that supplement. Well, there was a supplement in the Journal of the International AIDS Society that looked at stigma related, HIV stigma related frameworks. And they did include a repository of like 50 different, it was like a lot of different, you know, frameworks, but I'm not sure that's super helpful for this audience. But I do like that idea of sort of keeping track of how, you know, how different cancer researchers are applying it, and whether or not they're choosing to adapt it specifically or to just use it broadly to inform the development of their tools and surveys and that sort of thing.
Great, thanks. If there are, I'm just making sure I'm missing any other questions or hands raised. Katie, I know you're on, so let me know if there are any other questions. If not, I wanted to give a big thanks to Anne and Laura. Again, you know, I understand this week was, you know, a lot of stigma meetings at NIH, so thank you so much. Again, once again, thanks to our panelists from this morning. Thanks to Satish and everyone for getting us started. Benda, Andrew, and Laura, thanks again from all of us. So I think, Katie, are there any housekeeping things you want to mention? What time are we heading back? I know we're off to a lunch break.
We are. So yes, we'll have a lunch break from 1 to 1:30, and we're back here at 1:30, same link, and we will have 2 sessions this afternoon, another talk, and then some wrap-up comments. And so if you can be back by 1:30 or a few minutes before, Dr. Sylvia Cho will start us off with the next session. So thanks, everybody.
Thanks, everyone. Bye.
Test, test, test.
For timekeeping, I'll turn off my camera, and around 10 minutes or so, I'll turn my camera on just as a cue for time. But I'm sure you've all been briefed on how much time you have and the time we have for discussion as a whole. So, Katie, do you want to tell me when it's time to start, or should we, let's see, it's 1:31.
Go ahead, Council.
Yeah, I think we can start.
Okay, great. Well, welcome back, everyone. It's really a pleasure to be here. I am a program director at the National Cancer Institute's Health Communication and Informatics Research Branch. I'm serving as a moderator for this afternoon's first session. I hope you all had a nice, albeit brief, lunch break. This session is entitled Conceptualizing, Measuring, and Addressing Lung Cancer Stigma. So as we've heard, obviously, there's a lot of lessons learned across different types of stigma, but this is one area I think we've had a robust set of research that we really can use this opportunity to learn from. We have 4 speakers We'll start with the first one, which is Dr. Jamie Ostroff from Memorial Sloan Kettering. We'll be talking, I like your title, all questions. What is lung cancer stigma? Why we should care about it, and what we can do about it. So Jamie, please take it away.
Great. All right. Wonderful. So thank you very much, Sylvia, and really the entire organizing committee for both pulling us together and inviting me to speak during this workshop. Yeah, I really, sometimes the process is the content, but we have so many questions. And so these were sort of organizing principles for me, and it's my pleasure to make some comments. One thing, a bit of an unusual disclaimer or disclosure, is I often give this talk, and I want to be clear that I came to this topic through my work as a tobacco treatment researcher, educator, clinician. And undoubtedly, I checked the box that smoking is bad. However, and this is really important, that assessing and treating tobacco dependence in cancer care need not be a painful medical procedure. So my overall premise in the recent work I've been doing is to marry the work that I have long done in tobacco control and tobacco treatment in cancer with this newer area about stigma. And in truth, the recognition for much of my thinking in this area goes to the dialogue that I have and enjoy with many patient advocates in this space. So today I'm going to tackle. Yes.
Sorry to interrupt, but the slides are not showing fully. So you may need to reduce the slide because we are only seeing a small part of the slide.
Oh boy, that really may be above my pay grade.
We can share your slides if that's better for you, Jamie.
Yeah, I was seeing the whole slide as well.
And we can see the slides as well.
Yeah, I think you're actually fine.
Okay. It's just me then that I'm not seeing the slides. Okay.
All right. Well, let me see if I can, sorry about that. So these are the topics that I want to cover. I want to define and raise awareness about lung cancer. I am going to talk a lot about measurement because I feel, and many of the speakers have said, that we measure what matters. And in order to understand and address the stigma of lung cancer, we need a robust measurement tool. And then I am just simply going to introduce some promising strategies for preventing and mitigating lung cancer. And then the rest of the panelists in this presentation will be covering that important issue. So a picture tells 1,000 words, and I want you to sort of just, breathe, take a moment. These are the images of lung cancer. These are the media images, the historical images of lung cancer. And there's no doubt that these images provoke fear and stigma and are associated undoubtedly with the hazards of tobacco use. Essentially, tobacco, smoking, and lung cancer have a complicated relationship, and it's often been thought of this being the elephant in the room. A couple years ago, we wrote a commentary in JAMA Ethics that talked about the unintended consequences of anti-tobacco campaigns. And since that time, my awareness, and I hope the awareness of many of my colleagues in tobacco control, have been increased in terms of the unintended consequences. So what is lung cancer stigma? So first, it's been defined, it's the perception and internalization of a negative appraisal or devaluation of patients affected by lung cancer. It is ubiquitous, it is universal. As many as 95% of patients with lung cancer report experiencing lung cancer. And nearly half of those patients experience stigma during their medical encounters. This lung cancer stigma is often linked to nihilism and causal associations between smoking and lung cancer. And another point that I want to make is that intersectional stigma, which has been presented by several of the speakers, is associated with the multiple marginalized subgroup identities with known tobacco-related disparities. The Lung Cancer Project has done many of the sort of, if you will, Gallup polls or population surveys of lung cancer. And there is little question that, that generally speaking, people hold a negative bias towards people with lung cancer, and it's associated with shame, stigma, and hopelessness. Clearly a toxic brew of perceptions around an illness where essentially anybody with lungs can get lung cancer. Another survey that I want to share with you was done by our colleagues at the GoTo Foundation. And this basically says that despite the last 10 years of tremendous progress in the early detection and treatment of lung cancer, stigma, as shown in the comparison between the 2008 BAR's endorsement of stigma and the Black, which is 2018, clearly shows a marked increase in stigma in the past decade. Now, again, I'm not going to spend a lot of time on this, but I really want to emphasize that, like all the other speakers, this is a broad, multi-level context. And if we are looking at stigma, we need to look at drivers and intervention levers across all the sectors that we know from social ecological models of health. Turning back to specifically our work with lung cancer stigma, it was a little more than 10 years ago that Heidi Heyman and I began talking about measurement. And it was at a conference where we had both been invited by patient advocates to talk about lung cancer stigma. And it was during coffee after that meeting that we began to sketch on the back of envelope what would be 10 years of work looking at measurement. This is the conceptual model of lung cancer stigma that we have used. You'll see lots of familiar terms: perceived stigma, internalized stigma. And then we also wanted to emphasize that there were real consequences of stigma in quality of life and quality of care, and also that there was a variable experience of stigma moderated by several patient characteristics. So why does lung cancer stigma matter? As I've alluded to, it is associated with leading adverse outcomes for patients with cancer. On the quality of life side, we know that there's a growing body of literature that has identified stigma with reporting of depression, anxiety, low social support, and low engagement of social support, and disrupted sleep quality and other physical symptoms. Now, on the right are equally compelling reasons for us to focus and address lung cancer stigma, because there's a growing number of studies that are looking at the effect of stigma on quality of care. And these involved avoidance or delays in symptom reporting, tobacco treatment, screening, diagnostic workup, and et cetera. Really making this to be a modifiable determinant of adverse outcomes among patients diagnosed with lung cancer. So when we began doing this work, as I said, the first thing we did was, well, if it matters, we need to measure it. And this is a table that we reported in our first conceptual, our blueprint paper, as we call it, looking at the measures of illness-related stigma. And, it was really telling for us how much we had to learn and acknowledge the role of HIV in doing this work. But you can see there really, at the point we started this work, was one existing measure, the Cataldo, Janine Cataldo's work on lung cancer stigma, but all the rest of them were based on other illness models. The Cataldo Lung Cancer Stigma Scale was adapted from Berger's HIV scale with expert review. It has 31 items. It has a total perceived stigma, 4 subscales measured on a 4-point Likert scale, and it's got criterion validity with depression, self-esteem, and health-related quality of life. And then more recently, Lisa Carter developed a short form of 21 items. Now, we were intrigued by this measure, but at the time, what was missing from this measure was that it was unclear whether or not we had gotten the content right. And so what Heidi and I first started doing was looking at a model, a blueprint of measurement of lung cancer stigma that would have its foundation concept elicitation, lit review, an iterative patient feedback, and psychometric analyses. What emerged was a scale that we call the Lung Cancer Stigma Inventory with 26 items, 3 subscales, strong test-retest reliability, convergent validity with the Cataldo scale, and important is that a clinical threshold for lung cancer stigma, developing in multiple language and with a short form. There were 4 phases of this work, and I've listed the citations at the bottom. You can see that we really followed the best practices for development and validation of lung cancer inventories using qualitative interviews, quantitative interviews, iterative psychometric analyses, and then criterion validity with depression, smoking status, and most recently looking at engagement in patient advocacy. Here are some of the quotes from patients that were in our narrative. They are painful and hard to read, but they really illustrate the day in and day in encounters that are faced by patients who interact with the social world around their lung cancer. Our work was done with the psychometrics was done with a large sample of patients drawn from Heidi's clinic at the University of Texas at Southwestern and me in New York at Sloan Kettering. These are the 3 subscales from the LCSI: perceived stigma, internalized stigma, and constrained disclosure, with some items and listing of the Cronbach's alpha here. My last 2 slides really are a nod towards strategies for preventing and mitigating lung cancer stigma. And we have come to appreciate that we need to move way beyond description. And so having a measurement allows us to consider, develop, and test interventions at multiple levels across the cancer care continuum. And this was a really lovely paper that several of us here today contributed to, led by Dr. Heyman, and certainly illustrates that there are intrapersonal, interpersonal, and societal influences on stigma. And then equally important is a series of interventions that we proposed along the way. Dr. Banerjee is going to highlight our work looking at provider-facing interventions. And then I wanted to close with this slide in terms of future research directions, thinking a little bit about sort of a wish list of where I think our field needs to go. First is the refinement of lung cancer screening measurement. We need short forms so that they can be incorporated in cancer control studies. We need studies that look at low English proficiency, multiple languages, longitudinal measurement. I think that one of the thin spots in our literature is to understand the consequences of lung cancer stigma and quality of care across the continuum. And I've alluded to this before. In order to do that, we are going to need partnerships with lung cancer cooperative groups, because we're going to need to integrate our lung cancer stigma measurement in therapeutic trials, develop and test destigmatizing interventions, and then these last 3 cross-cutting themes to foster interdisciplinary collaborations that include survivors and other patient advocates, to continue the work that we're doing today, building capacity and strengthening a network of stigma investigators in cancer, and of course to address disparities and intersectional stigma. I love these 3 non-peer-reviewed papers. These were really some of the things that that have really been formative in changing my thinking. And I share them with you, particularly this one written by a physician about 2 years ago in the New England Journal of Medicine. And it was a wonderful article about entering a guilt-free zone and how we talk with patients about smoking. And then last, I want to really thank, with much gratitude, colleagues who make this work meaningful and impactful. And these are both individuals who are colleagues and investigators, but you'll see here on the right, clear partnerships with advocacy organizations, member organizations, patient and caregiver, and of course, clinicians that make this work. And the last point I want to make is that all of this work was supported by the funding opportunities that were launched in 2002, and we have had R03, R21, and R01 funding from this funding mechanism. So my last moment of gratitude is really to the NCI for recognizing the importance of this work and the need for us to continue this work to improve patient outcomes. Thank you.
Thank you so much, Jamie. Wonderful. And I encourage everyone to type in your questions or comments as we continue, and we'll have a discussion at the end. Jamie, your talk is now followed nicely with a second talk by Dr. Smita Banerjee also from Memorial Sloan Kettering, focusing on empathic communication skills training. So talking about going from description to intervention. So Smita, the floor is yours.
Thank you so much. Thank you. Thank you, Jamie, for that beautiful description of stigma. I am going to skip over the description now and really focus on the provider-focused brief intervention to reduce lung cancer stigma. So I wanted to begin with this slide that Jamie presented that really talks about there are multiple ways of addressing lung cancer stigma across the cancer continuum. I'm particularly going to speak about this provider-focused intervention that we developed. So from the research that we've been doing for quite some time now, we know that empathic communication is associated with higher levels of patients' treatment compliance and lower levels of distress. And then what we also saw was, from our own data, was that lung cancer patients across varying stages of disease, for them, good patient-provider communication was associated with lower levels of stigma. And so that got us thinking that can we target empathic communication as a way and utilize that to reduce levels of stigma that was experienced by patients with lung cancer. So Jamie and I received an R21 from NCI to develop and pilot test an empathic communication skills training for oncology care providers that were treating patients with lung cancer. So for that, I'm not going to go into too much detail about the study, but we developed a communication skills training module. Aim 2 was we examined the feasibility and acceptability of the training, and aim 3 was we pilot tested the effects of the training on patients' reports of stigma, perceived empathy, satisfaction with clinician, patient communication, and so on. So for phase 1, so this study was divided into 3 phases. For phase 1, we did interviews with 12 lung cancer patient survivors from the GoTo Foundation. At that time, it was called the Lung Cancer Alliance. And we needed these stories to really help us create clinical vignettes that were true to real life. What happens, between patient and the provider. We used that information to develop our training. Phase 2 was we recruited 30 oncology care providers from the Memorial Sloan Kettering Thoracic Disease Management Team and the Pulmonary Medicine Service. And these participants, they came to us. This was an in-person training, and we did a 2-hour training followed by some brief surveys that the providers completed. Following that, following the training in phase 3, we recruited 6 patients per provider, 3 before training and 3 after training, to really look at the effects of training on patient outcomes. So one of the things that we found, and this was fascinating, was what were some of the stigmatizing experiences that patients and survivors shared with us? And this is just a snapshot of what we found. So repeated probes about smoking, clinicians asking them over and over again if they smoked, different clinicians asking the same question. So the repeated probes were problematic. Providers making presumptions about the patient, that even if the patient is saying, I haven't smoked, still kind of making presumptions that they were doing a few things which they weren't. So disbelieving the patient, as well as making some blaming statements. So those were some of the stigmatizing experiences that patients and survivors shared with us. Based on that, we developed our training materials, patient-provider interactions that were used in the role play. So our training was a 2-hour training where we did an introduction to our conceptual model that we were using. There was a didactic on empathic communication skills training. And then the bulk of the time was really utilized in small group role plays where we used clinical vignettes and the participants engaged in role play sessions with our trained actors or standardized patients. This was a blueprint. So based on what we had heard, the stories that we heard from survivors and patients, there were 7 strategies which provide kind of a roadmap to addressing lung cancer stigma in order to reduce this. And then I'm not going to go into too much detail about these strategies. We have published on this in Translational Behavioral Medicine. We have a paper that describes the training module in detail. And if anyone is interested, I'll be happy to send a PDF. We then did, we wanted to see how did the providers that participated in the training like the training. So what we, as you can see from these numbers, the providers that came for the training, they really liked the training, and we got very high evaluation results from the providers. The tricky part was looking at patient outcomes. We really wanted to see some movement in consultation and relational empathy. But as you can see from these numbers, the pre and post, the numbers were so close together. We had a ceiling effect where there was not too much room for change. We did see some change, and I'm going to present that to you in a minute. And we saw the movement in the CAPS, the consumer assessment of healthcare providers and systems in that measure, in particularly for providers explaining information better and being more knowledgeable about patient history. So based on the R21 results, we published a paper in CHEST that really provides the outcomes of the study. Now, the take-home messages from the R21 were that clinicians who treat patients with lung cancer, they can play a pivotal role in reducing lung cancer stigma. Empathic communication skills training seems to be feasible, acceptable, and a promising intervention. We also saw from our R21 that taking a smoking history or talking about smoking need not be a painful medical procedure. And so based on all that we found, our next steps were to examine the effectiveness of a multi-site virtually delivered empathic communication skills training in training providers from community oncology settings. And that is the R01 that Jamie and I received last year. Overview of the training was, this is a 2.25-hour training, which will be conducted virtually via Zoom. We are in the post-COVID, or we can still call it the COVID world, and so the trainings will be delivered via Zoom. The training is for the didactic for the training includes a 45-minute presentation, where we talk about stigma experienced by patients with lung cancer, consequences of that stigma, and empathic communication skill as a strategy to reduce stigma. As with the training before, bulk of the time is spent doing the role plays with standardized patient actors, and we have trained tobacco treatment and communication facilitators providing tailored feedback to the participants. So at this point, we are working on a national multi-site trial of our training to promote reducing stigmatizing interactions with OCPs treating patients diagnosed with lung cancer. For AIM-1, we will be evaluating the impact of the training on providers' uptake of communication and empathy skills. AIM-2 we'll evaluate the impact of the training on patient-reported outcomes. And we have the intervention arm, which is the training as well as a waitlist control. And then for aim 3 is the data analytic aim, where we'll be examining potential moderators of outcomes. So in terms of the design, it's a cluster randomized control trial of 16 different sites, and the sites will be randomized to the empathic communication skills training or waitlist control. We will be recruiting 9 to 11 providers per site, and then there is some information around eligibility that I won't go into that much detail. We will also recruit 6 unique patients per provider, 1 pre-training and 5 post-training, and we'll really, for this R01, we really want to look at the impact of the training on patients. Now, we are we've just started our second year of the grant. And for the first year, what we wanted to do was we wanted to take a fresh look at our training material, and we wanted to make some adaptations, some changes based on feedback from scientific advisory group and a patient advisory group. And we were fortunate enough to receive a grant from American Cancer Society, which allowed us to convene a one-day key stakeholder conference in New York City in October. We presented the module, and we got a lot of feedback on further adaptation of the training content. So this is just, some of us who attended the training in person. We used Sterman's kind of 12 distinct a priori content modification themes, and we wanted to see what modifications were recommended from participants who participated in the training, either in person or virtually. So this was a hybrid conference. There were 8 out of 12 content modifications recommended. Things that needed to be tailored, tweaked, etc. There were some elements that were recommended that we add to our curriculum. There were some information in the training that was too much, and so the recommendation was to remove it. Some things were recommended to shorten or condense. Some aspects of the training, we were recommended to lengthen them, to substitute some stuff, and then to reorder elements in order to make a more impact of the training. So as of now, the content modifications have been completed. We have created new patient-provider interaction scenarios. We have included smart phrases into the didactic. We have reshot some of our exemplary videos, and we have made some modifications to provider and patient outcomes. So in terms of site enrollment, 4 sites have been enrolled. The paperwork, it's reaching the final stages, and we are going to start data collection very soon. So that is kind of my overview of the R01. I also briefly want to talk about another adaptation of the training, where we are working with 2 hospital systems in Nigeria to adapt this training for and understand how lung cancer stigma works in Nigeria. So that study is still going on, and we'll have more to report on it very soon. Finally, I would like to thank our entire study team, the GoTo Foundation for Lung Cancer, American Cancer Society, our patient advisors, our research advisors, and funding support from NCI, as well as from the American Cancer Society National Lung Cancer Roundtable. Thank you very much.
Thank you, Smita. And thank you for all those excellent questions. Keep them coming. We will have a chance to discuss them all. Our next speaker is Dr. Narjas Duma from Dana-Farber Cancer Institute, who will be talking about, well, the title of your talk is Please Don't Tell My Family. So Narjas, I don't know if you're sharing your slides or you can take it away.
Hi, yes, I will share my slides. Hi, everyone. I'm delighted to be here. I want to provide the perspective of the oncologist and the story. I strongly believe in the power of storytelling. So I'm going to share my screen. I do have other screens open. We are grant. So if you see it, provide feedback. So let me make sure we're all good. Dr. Chu, can you see the presenter's view or the full?
Yes,
slide?
it's perfect.
It's good? Okay. So I have a double monitor. So as Dr. Chu mentioned, I'm a thoracic medical oncologist. I have a particular focus on women with lung cancer. And these will come to play. These are my disclosures. And as I say, I strongly believe in the power of storytelling. The story I'm going to share with you changed my career pathway and ultimately a lot of the things I do. I was being raised or mentored to be a phase 1 trialist, and this patient changed everything. So the title of my talk is Please Don't Tell My Family. And this comes as Mary immediately asked me to don't tell her family when I disclosed the results that the lymph node biopsy was positive and she had metastatic lung cancer. To put things in context, I was a first-year fellow at the Mayo Clinic in Rochester. I have been studying lung cancer from the other side, from the chart review for the early phase 1 clinical trials. My interaction with newly diagnosed patients as a first-year fellow was limited. So I was stunned that she would have asked me to don't disclose the results to her family. I went to my attendant and I shared this, and at the beginning I thought it was normal, but my attendant told me, why did she want nobody to know? Then when I asked, she said that she was afraid of the stigma associated with lung cancer. And here, a small community in Minnesota, a person she knows was diagnosed with lung cancer a few years before. And that person was isolated. It was not interacted with as much at church, which was a very important place for my patient. My patient was a never smoker woman in her 40s. Was she not only dealing with a diagnosis of metastatic lung cancer, she also was dealing with the stigma. As she came to the visits, we identified that she had an EGFR mutation, and she was started in targeted therapy. When I shared the results with the patient that she could get targeted therapy, she immediately told me that that was good, so her family wouldn't notice that something was going on. She was so afraid, no her husband, no her children knew. I got involved with palliative care, we involved psychology, we continued to have conversations with her, and she was adamant. I talked to her, I would talk to her family. I even offered to drive to her community and talk to her family in person outside of the hospital walls. But she was more afraid of the stigma with the disease than the disease itself. Unfortunately, she had disease progression. We targeted therapy and she started chemotherapy. She progressively deteriorated, and for the first time, after a year and a half of treating her, her family started coming to the visit. I realized that that was it. My patients had to disclose the diagnosis to her family. But it was not. She had prepared for this moment and created a small notes that she would give the medical assistant, the nurses, myself, we her family, sharing the words, please don't tell my family. As the time progressed, she developed, unfortunately, brain metastasis, and she was in the ER. Now her sister was the only other person that knew about her diagnosis. And I remember telling one of my colleagues, she's in the ER, they're gonna tell her. Little did I know that my patient, in fact, had prepared for that as well. She had notes. She had requested me to put it in her chart. She had educated and trained her sister to talk to the ER doctors that if any family member would come, they wouldn't tell her. I accumulated every single note that she sent me, those tiny little notes, handwritten, to remember my journey and to remember why I changed my career path of being a phase 1 trialist to focus on women with lung cancer. Those words still stay with me today. And unfortunately, we lost her to the disease. And at the end, I became close to the husband without telling what was happening. And he cut a piece of the obituary and sent it to me. I remember getting it in the mail at the Mayo Clinic where I was training and saying in the obituary that she had died of breast cancer. So she had told all her family at the end of her life that she was dying of breast cancer because she didn't want people to know. We practice many types of communication. And while this may be an extreme case, this is a case that's actually commonly seen in my clinic. My clinic focuses in young women with lung cancer. And I can tell you that as somebody who also treated breast cancer in the past, you cannot see patients with several types of gear as they continue their journey getting therapy. But the waiting room for lung cancer is very different. The waiting room for lung cancer is not full statements. And today, I continue to see many of my young women wearing pink while wearing to see me, because they feel more comfortable sharing that they have a breast cancer diagnosis than a lung cancer diagnosis. And where is that? Well, in part it's our fault. In part it's our fault because we continue to define our patients by their disease. We have created many things, including inclusive language, instead of using lung cancer patients with lung cancer, because the disease doesn't define it. But the healthcare system continues to fill on this stigma. I train, I work and talk to my nurse practitioners and nurses and medical assistants to try to protect my patients for that. For my patients that told me that even when they're at the oncology clinic, the stigma follows them to the lab. It's a new phlebotomist who says what you're here for. And they say treatment for lung cancer. And the first question that comes out is, do you smoke? And one patient have a very good reference saying, if you have colon cancer, will somebody ask me if I eat red meat? Probably not. And these questions and these interactions are present with primary care doctors. They're present at several levels of healthcare. Why is this a big problem? Well, it's a big problem because our patients are dealing with a lot already, and adding a stigma doesn't fix the problem. It just makes it more complicated. And having to deal with that is an unnecessary issue for our patients. They have a large number of side effects. And the big issue is that the incidence of lung cancer in women continues to go up every year. But the stigma that is associated with lung cancer decreases the awareness about the disease in women. Women take twice as long to be diagnosed with lung cancer compared to men in cross-match cohorts. And if you're a woman of color, it can take up to 3 to 4 times longer. Back in the day before COVID, 1,000 women were asked in the street, what is the #1 cause of cancer death in women? And only 1% reported lung cancer. Lung cancer killed more women than any reproductive organ cancers combined. But it's known in the media, and that's in part with the stigma of the disease. So the stigma is not secondary only to my patients' feelings and survivorship, but the delays on diagnosis. Many of my young women have gone through many lines of antibiotics, steroids, COVID testing, even mammograms, because the stigma decreases awareness, and awareness delays diagnosis. And for the first time in history, younger women are getting lung cancer more often than men. This is the result of a New England Journal of Medicine paper that was published in 2018. And I remember seeing the paper coming out, and it's like, oh, it's going to be in the news. People are going to talk about this. The media coverage was poor to non-existent. We don't like to talk about lung cancer. But that is many of the consequences of not wanting to talk about lung cancer are being an underfunded cancer, understudied. Yes, we have new drugs, but many other issues are not addressed. So I may be running out of time because I see Dr. Shu came back, but there are many everyday consequences of lung cancer stigma to women: delays in diagnosis, depression, anxiety, isolation. It really affects the communication and generates a poor relationship between patients and physicians. and the time that they need us the most. Lung cancer has many faces: Native American, men, women, members of the LGBT community, or veterans. And we're continuing to see more and more how this changes. There are campaigns, and this is a campaign by the Lung Cancer Alliance that has impact. It may be very straightforward for some people, but we need to be straightforward now. Crazy ants don't deserve to die. No one deserves to die. There are many risk factors for cancer. Tobacco is one of them, but many other risk factors. How I train the staff that works with me, that treats and manage patients with me, is with the 3 principles of cultural humility, which includes lifelong learning. And the lifelong learning is avoid assumptions and stereotypes. Desire to improve the dynamics between the physician and the patient, and make sure we have mutual respect and nobody's considered to be lower than somebody else. Something that we cannot talk and finalize talking is that stigma is related also to cultural differences and healthcare beliefs. As an immigrant, in Latin America, the word cancer is considered to be a bad word. It's barely spoken. And those patients move to the United States, live in the United States, and there are many cultural differences. So stigma on lung cancer may not only come about the disclosing diagnosis. It comes about interactions with the family. It comes about support from the family. I have seen this in my Latinx Hispanic patients, in which they don't receive the standard Latinx support from their families because it's lung cancer. A lot of patients are cut off of their families as well. So stigma is not only about interactions with healthcare, it also affects interactions in the family nucleus and it is really correlated to cultural differences and healthcare beliefs. As I come to the end of this, I want to end with a question for everyone, because our patients are more than the lung cancer diagnosis. So my question to all of you is, do you really know your patients beyond their diagnosis? And that is the beginning to understand that this disease doesn't define them. And lung cancer is as a cancer like any others. Thank you, everyone.
Thank you so much, Narjas. I think you really highlighted how much we sometimes fail to see the whole person. We define people by their disease or their behavior, and this whole discussion of stigma and this whole panel, I think, really highlighted the importance of personhood or humanity. And that's a really wonderful segue to our fourth speaker, Mr. Jim Pantelis, who will be engaging in a discussion with Robin together on a few questions. So I'll let you, Robin, take it over.
All right. Thank you so much, Sylvia. And thank you, Narjas, for those wonderful comments. And again, I think this is a nice balance now to be with Jim to recognize the patient perspective in this conversation that we've been having all morning and all afternoon. And so with that, Jim, I'd like to take an opportunity for you to please introduce yourself to the audience and tell us about yourself and your personal connection to cancer.
Okay, thanks, Robin. My name is Jim Pantelis. I'm a 17-year late-stage lung cancer survivor. I'm also the son of a mother who died of pancreatic cancer and a father who died of lung cancer. And like everyone else, I'm a host of other things. I'm the father of 3 fairly young daughters whose ages are 12, 14, and 16. And that'll be an issue later in this conversation, I'm sure. I'm a disabled Navy veteran with what the VA calls asbestosis complicated by lung cancer and COPD. I'm a former cigarette smoker with an over 30-pack year history of smoking. I've lived and worked in asbestos contaminated spaces, spent most of my life living in cities with higher than average air pollution. I raised parrots and have been around birds and burn dander for much of my life. And like everybody else here, I continued to breathe through all of it, which is why I'm still alive. In short, my risk factors were many, but that's my association with lung cancer or with cancer.
Well, thank you so much for sharing that. And as we've heard throughout the panel this morning, certainly the tobacco related stigma that presents itself. And with what you're comfortable, would you please share how you've experienced that, as well as other stories or other circumstances that other survivors have also shared with you of their experiences with tobacco related stigma?
Okay. Lung cancer obviously remains tied to tobacco to many people. Go-To Foundation did a study I think they published it in 2018, where they said that stigma within the clinician community reflects that of the general community as a whole. So for us to think of the stigma of lung cancer, we have to tie it to how we're treated. There are still institutions that tell the recently diagnosed that they need surgery, but they have to wait 30 days and prove that they haven't smoked for 30 days before they can get that surgery. That's contrary to NCCN guidance and everything. We still have physicians that think their lung cancer patients are lying to them if they say that they're a never smoker. And we know at this point, we know that 15 to 20% of all people diagnosed with lung cancer are going to be never smokers. And the single most common response for almost everybody is the almost universal, oh, smoker, as soon as you say that you have lung cancer. And it comes from everyone. And it permeates the discussion that you have with most of your clinicians, because there's an assumption that you knew that this was coming because of your behavior. This doesn't happen as commonly with people who have heart attacks or people that have COPD or other diseases that are as linked to tobacco use as it does in lung cancer. So it kind of permeates everything about our disease.
Thank you again for sharing that perspective. And there's been an active conversation in the chat that I wanted to bring up, and it's something you and I touched on in some earlier conversations, is the unintended consequences of our public health messaging, particularly in this case around anti-tobacco public health messaging and how that can contribute to the broader societal perspectives and stigma. Can you speak to your thoughts on that public health messaging and those unintended consequences?
Well, I think we've spent the better part of the last 50 or 60 years combating tobacco use. And we've done it with as many scare tactics as we can, with as many convincing arguments as we can develop. And this kind of ties back to my little girls, right? My 12-year-old, my 14-year-old, my 16-year-old, they all go to schools and they have these pictures of what smoking does. And it's mostly tied to lung cancer. And they're posted on the walls in the schools. So we're indoctrinating people from a fairly young age that smoking causes lung cancer. And even in the instances where the picture isn't of someone with lung cancer, it's implied, or it's allowed to. No one says when they show a woman without a jaw who died of lung cancer that she didn't die of lung cancer. But most of the population assumes that she did. And the problem with all of that is the unintended consequences. You know, the lung cancer patients have the highest suicide rate of any cancer. nihilism is very much a factor. There was a UC Davis report that came out, I think in 2016, that said that a full 26% of people diagnosed at stage 3B or stage 4, which is inoperable lung cancer, refuse first-line therapies. The story that Narjas just told us about somebody that didn't want her family knowing, in the male population, what ends up happening is that they just don't accept any treatment. And that in and of itself is a form of suicide, but it's not recognized that way. They have those same patient groups, the stage 3B or 4, have a higher likelihood of not seeking a second opinion. And when such a large proportion of lung cancers are treated at the community hospital level, and there's such a difference in treatment options between the cancer centers at teaching institutions and the remote hospital up in northern North Dakota, whatever, not seeking that second opinion it can be deadly. And it all comes down to what a patient expects and how much responsibility they take for their own disease. If they think that they caused it themselves because they have a history of smoking, they don't want to spend what little assets they have left that their family is going to need to buy an extra 6 months by going for a second opinion, by taking on those extra treatments, by taking on that extra expense. And if their primary care physician is aligned with that philosophy that, yeah, John, you pretty much brought it on yourself. We talked about your quitting. That's the way things end up going. So it delays care. It prevents care. It delays screening. We have a screening program now that could be finding more lung cancers earlier at treatable stages, and yet it's so poorly used because you're dealing with that population that has that 30+ pack year history of smoking, and has been told for most of their adult life that they're going to get lung cancer.
Thank you again for sharing these thoughts, and certainly with the remarks so far, we focused on the individual patient, and it's come up a couple times today too. What is the role stigma has in what we might consider downstream effects of prioritizing, in this case, lung cancer research or stigma-related research? What are the downstream negative effects on investments in this area of science?
I've spent the better part of the last 12 years going with Lung Cancer Alliance and Longevity and other nonprofits to go call on Congress, right? And you meet with, most of the times you meet with staffers, and staffers are always really nice and willing to talk. And occasionally you'll meet with a member of Congress or the Senate. And sometimes they'll tell you what's on their mind. And sometimes that's that, well, I appreciate that you're out here and I'm really impressed that you've lived this long with this disease. But our own institutions are often telling us that you have what is a preventable disease. Why should we fund it more? That's been changing. That has been changing, and it's changed over time. We used to scream about not getting any funding, and I have watched as the funding for lung cancer research is just driven upward dramatically. But it's mostly bench science and treatment science. What we're not hitting yet to any large extent, and Jamie mentioned this a little bit. I mean, Jamie's gotten more funding than most people in the soft science side of lung cancer and lung cancer prevention. What we're not getting is the money to understand the stigma and how to overcome it. We're not getting money to understand the causes and all of the causes. I think I had asbestos exposure and I was a smoker. I'm sorry, Jill Feldman, I said the bad word smoker. But we're also trying to deal with how we change the language around lung cancer. But if we're not, when I looked it up, the last study that was done that showed the variance between just being a smoker and the risk factor involved and being a smoker that was also exposed to asbestos came from 1964. We don't have studies that say if you live in Steubenville, Ohio, where pollution is really bad and you smoke, this is what your likelihood of getting lung cancer is. We don't have the epidemiological studies. We haven't funded those. We haven't funded the soft studies. We are starting to fund, thank God, we've started to fund more of the bench science, and we're attracting more young investigators to the field. We're starting to fund more science that's delivering treatments. I mean, we have far more treatments available than at any other time, and it's wonderful. But now we're at a point where we need to start thinking about funding comparative effectiveness on those treatments, because we finally have options and we have people that are living. But that's also kind of affecting the stigma, because there are people out there that now know people like me that have survived, and they think that it's curable. So that removes the, you've survived 17 years. We could talk about surviving the survival, but we need a lot more effort in the softer side of lung cancer, and we need to continue to improve the funding for all of lung cancer research.
I'm going to give you just one last question, and then we'll switch back to the broader panel and open it up to the full audience for questions. But maybe just in a couple, three, sentences, which I know is hard to do, really, can you speak to this audience about the importance of having a patient voice in the research process, in the research study, so that again, we have these, in this case, stigma at the top of mind, and to again, just like we heard from Narjust, and we're hearing from you, to have the actual patients as partners in this research.
Well, I think a big part of it is that we're better at disseminating research findings than scientists typically are. If we're involved in the research, I think we do a better job of getting that word out to the community. I think somebody defined a form of porn as being disabled inspirational porn at one point, and that's not what we do in research. We're not there to inspire people because we're working through our disabilities. We're there because we care about the science. I sit on IRBs at University of Michigan and the VA locally. I've sat on a couple of CIRBs for NCI, did that for 6 years. The big takeaway for me was that I was able to go and talk to my community about how research has changed in that 6 years at NCI. When I started, there were very few studies going on at NCI that were directly tied to lung cancer research. And when I finished the end of last year, well over a quarter of the studies were directly tied to that we were reviewing were directly tied to lung cancer, and a bunch more were ancillary in their relationship to lung cancer. They were solid tumor driven or brain metastasis driven. But those avenues are open to anybody that's interested in participating. You can get involved in IRB work. You can get involved in peer review. I do peer review for PCORI and NCI and CDMRP and a bunch of others. I work with the nonprofits when I can, and I think that the more you do, the more you get asked to do. So it's kind of, it's worthwhile work.
Great. Well, thank you so much again for joining us this afternoon for this important conversation. I'm going to turn it back over to Sylvia. We have about 15 more minutes, I think, in this whole panel session for more Q&A. So thank you again, Jim, so much.
Thank you.
Thank you, Jim. Thank you, Robin. I invite everyone on the panel to turn on your camera if you're comfortable. There are lots of questions, and I'm sure we won't even get to scratch the surface, but maybe for a starter, I feel like there is an overarching theme about wanting to learn about, you know, when we do one thing, we could have consequences on others. So tobacco control messaging, there's actually a lot of talk of using sort of stigmatizing a behavior as a way to maybe create a kind of norm, social norm of, I'm currently working obviously a lot in vaccine acceptance space, right? And we think about COVID campaigns where we, put the behavior of vaccination up as a way to then connect to other things. And I saw a question on alcohol messaging and some of the ways we may want to think about the downstream effect of certain types of messaging that may incorporate elements of shaming or blaming. So if anyone want to just sort of expand on these kind of one area, whether you're caring for a patient with a particular cancer, cervical cancer, lung cancer, and so on. And then maybe you're working with a behavior, you're trying to promote. Another one is actually obesity, right? There's a lot of what we call weight-based stigma and weight shaming. So just talk a little more about kind of how can we make sure that we are connecting the dots so we're not doing one thing at the harms of other things.
If we can add to that, I think when we are doing campaigns to prevent something or to decrease something, we need to interview or communicate with patients on both sides of the spectrum, because we always include the ones that are healthy, the ones that we need to work with what patients on the other side we see, and also include caregivers. I can tell you, I see a lot of women, but I see a lot of men too. And I can tell you the influence, and I did a large study of 400,000 patients that the wives have for heterosexual relationships on the impact. So incorporating caregivers, I think, is also important, and both sides of the spectrum. And I agree with you, like the weight loss has also fuel into smoking, because a lot of women are attached to the weight gain with smoking sensation, and then they gain weight and then they receive weight shame in clinic. And that's what all of my women have told me. It's like, I gained 10 pounds when I lost weight. So now my primary care doctor is upset at me, but then I quit smoking. So to make sure it's seen as an ecosystem.
Thank you. That's excellent. We're generally not so good at that. We often joke that NIH is made of diseases and body parts, right? It's easier to silo than connect. So if others want to comment a little more on these connections.
Well, I just think that we've spent an awful lot of time and money attaching to tobacco to lung cancer, and naming and blaming patients for their own disease. And the only ones that are really out there that are saying anything positive about what's going on right now is Big Pharma, because they're trying to tout they're trying to tout Keytruda and saying that you can live longer with lung cancer. And I would just like to see some type of positivity coming out of institutions like NCI or NIH that say, look how much we're doing, look how far we've come, and we've just gotten started. That said, I think that the moonshot for cancer is a step in the right direction. We're just not taking it into the lung cancer space yet. Everybody's thinking it's cancer, and lung cancer is preventable, so it doesn't count. I think we need to say something about that.
Sylvia, I'll just make two more comments on this important topic. One is that this is a really critical stigma policy question. So we're going to talk throughout today and tomorrow about a research agenda. And here I would say that one of the policy questions is to disseminate messages around destigmatizing messages around tobacco with a more complicated or nuanced messaging. All public health officials really, when we give our lectures in Public Health 101, we point to tobacco control as the unbridled success of modern public health. However, it is only recently that we have seen that that this message that that has been successful and in part attributable to reducing prevalence is not a one-size-fits-all. It's not connecting with vulnerable parts of our population, and that if we care about that, it is making this is also not just important policy, but an equity and disparities issue. If you turn off the television or the bus stop or any other public campaign that is hard-hitting and fear-arousing, we are not connecting with those patients, and our tobacco rates and vulnerable populations really demonstrate that.
Excellent. Thank you so much. Yeah, please, Smita.
If I could just add one more thing, as a researcher also, in our head, at least in mine, there is a connection with lung cancer and tobacco smoking, which recently came out as we were doing our adaptation of our empathic communication skills training in Nigeria. So we are talking with the Nigerian colleagues, and we are almost starting data collection, and they said, hold on. One of our patient eligibility criteria was that they must have been current or former smokers. And they said, we don't have any smokers. The lung cancer patient population that we have are not necessarily smokers. And most of the folks that we see, they use a lot of wood burning fuel for cooking. And there are some other reasons, but smoking is not, yes, smoking is a factor for lung cancer, but that's not our patient population. And we were like, oh, that pauses are, we were thought we know what we are doing, we are going right in. And so we are doing some focus groups with lung cancer patients. We are about to get started, and I'm sure we're going to learn a lot, because they said, besides that, the stigma comes from, understanding that you must have done something badly in your prior life that you got cancer. Here, we have to start addressing some of those other reasons as well. And so that was a wake-up call for me as well.
That's a great illustrative example of when we're doing this kind of work across social, cultural, political context, how much we need to, listen and understand the situation before we intervene and do our messaging. And a quick follow-up, I saw a question, Smita, about whether you've considered implementing these comm skills training to other aspects of the healthcare team, from valet, person to a checkout person, and how we are really trying to think more about team-based care. And do you think physicians are uniquely positioned, or are they really just a start?
So when we started the study, when we started when we got our first R21, the goal was to work with physicians. But when we did our interviews with patients and survivors, we learned that It's not just the physicians, it's the nurse practitioners, physician assistants, clinical nurse specialists. So we need to work with the healthcare team. And we said, okay, so in terms of providers, we expanded our eligibility criteria and we said we will, for this R21, it was a small study. We were just training 30 providers, but we started working with, we recruited nurses, nurse practitioners, physician assistants, and physicians for the study. So now I completely agree that it's, besides the clinical care team, everyone else that's coming in contact with the patient must also be trained. And that's where we need to go.
Thank you. Yeah, excellent.
We haven't gone there yet.
Yeah, and I think Narjas may have something to say about that too.
So more than that too, what it feels to that is that a lot of stigma associated with stereotyping and the unconscious bias that develop during medical training. During medical training as a physician, you are designed to answer questions in 1 minute and 30 seconds for your step 1 and step 2. So you put patients in categories. So we're talking about stigma training physicians when they're seeing the patients. It needs to be started at medical school when these associations are created in the student's brain. I teach the lung cancer course and like the students come full with stereotypes right away into the class. And these are first years or second year medical students. And the same happens to physicians assistants and nurse practitioners, how we're taught to make associations to answer these standardized tests, feeds on this stereotyping. So I think early on is very important. Not only for stigma with lung cancer, but for other cancer health disparities, stereotyping and unconscious bias that affects our patients.
Excellent. Thank you. I'm sorry that we won't get to all the questions. I think they were really spot on. I saw that a lot of people followed up on Bill's comment about whether it's stigmatizing a behavior or pointing at the industry behind, sort of the source of a certain kind of risky behavior. I think there's been some, demonstrated successes in really looking at that level of, if you want, public health messaging. I'm not able to keep up with everything, but I don't know if anyone has sort of last minute comments, or Katie, is there anything you think in 1 or 2 minutes we can resolve?
No, I don't think we can resolve any of this in 1 or 2 minutes, but I do think that this has been fantastic. And I don't know if any of the panelists have anything else they'd like to add. I just think this is so rich and complicated, and we have such thoughtful minds that if anyone else has anything to add, I know we'll continue this conversation, but.
I saw some notes about sort of the role of negative emotions or fear-based messaging and shame. Yeah. Is there a role in anything we do, any communication, and how do we, think about that? Obviously, in my work in the COVID front, this is everywhere, right? There's a lot of emotions going on, and I think disinformation campaigns really leverage people's fear and even hatred in some cases. So a lot to chew on between the different domains that we're working on. So I think it's 2:45. I want to thank the panelists. It's been amazing. You've offered so much invaluable ideas and data and personal insights. And we'll turn over to Chipper for the next session. So thank you.
Hi, everyone. I'm Chipper Dean, developmental health psychologist and program director in the behavioral research program here at NCI. Much of my work is in populations with stigmatized aspects of their identity, including behavioral health, that is to say mental health and substance use conditions, racial and ethnic minorities, and sexual and gender minorities. So I'm very excited to hear from our next panel of speakers today on intersectional stigma. Let's see, do we have our speakers here? It looks like we do. Excellent. So without further ado, I'd like to introduce Esther Freeman and Sigrid Collier. Dr. Freeman is Director of Global Health Dermatology at Massachusetts General Hospital and Harvard Medical School, as well as the Director of Clinical Innovation and Education at Massachusetts General Hospital Center for Global Health, and also Associate Professor of Dermatology at Harvard Medical School. And Dr. Collier is a board-certified dermatologist and an acting instructor in the Division of Dermatology at the University of Washington. Welcome, and please take it away.
Great, thank you so much. And Dr. Dean, can you see my slides?
I can.
All right, great. So a pleasure to be here, and really what an incredible panel to follow. I think just so inspiring for all of us. And we've heard some small points about intersectional stigma this morning, and it's really my pleasure to be part of this panel talking about intersectional stigma this afternoon. So my name is Esther Freeman, and as mentioned, I'm the Director of Global Health Dermatology at Massachusetts General Hospital and Associate Professor at Harvard Medical School. And I'm joined by Sigrid Collier, who did this work as part of her Fogarty Fellowship, and she's at University of Washington. There we go. So intersectionality was originally used to describe the marginalization of Black women who were targets of discrimination both because of their race and their gender identities. So using this lens of intersectionality, we can really begin to understand the burden of multiple different marginalized identities related to healthcare, such as HIV and cancer. And although we know that HIV and cancer are traditionally stigmatized health conditions that can be associated with delayed healthcare seeking and poor treatment adherence, less is known about intersectional stigma among people with HIV and cancer. And in particular, what I'll be talking about today is in Kaposi's sarcoma in resource-limited settings, where we have the additional piece and component of skin disease. So before we talk about stigma, I thought I'd just give you a small reminder about Kaposi's sarcoma if this is not something that you see on a daily basis. So Kaposi's sarcoma is one of the most common HIV-associated cancers in sub-Saharan Africa, even in the modern antiretroviral therapy era. And sometimes I get questions about how common really is this. And I'll just say that compared, the incidence in areas in sub-Saharan Africa where we work is actually higher than the incidence of prostate cancer in the United States. So really still a very highly incident disease, even with antiretroviral therapy being increasingly more accessible. So Kaposi's sarcoma can occur both in HIV negative and in patients living with HIV. It's associated with HHV8, which is human herpes virus type 8. Today, we're going to be focusing on Kaposi's sarcoma in HIV positive individuals specifically. So I thought I'd share a couple of pictures of 3 of my patients that I take care of in Uganda and Kenya. So on the left, we can see a young man who has HIV-associated wasting. You can see his left leg is really thin. And on the right leg, you can see that he has really got infiltrated and studded with tumors. He has a secondary bacterial infection, which means that he actually has some flies that are kind of coming with him with a very strong odor. And he was actually evicted from his village because of the smell. He was also a fisherman and could no longer fish because obviously it was very difficult to stand in a boat. And the stick underneath the chair below him, you can see is his walking stick. The middle photo is a young woman who has Kaposi's sarcoma in the mouth. We frequently see oral involvement, and you can also see some tumors studding her cheeks. So this is often in a very visible, physically visible location. And the lower right-hand corner is one of my patients with really strong woody edema. So a lot of infiltration in the lymph system, and this can lead to a lot of discomfort and difficulties with doing activities of daily living. So with these cases, you can begin to see how patients diagnosed with Kaposi's sarcoma can experience multiple intersecting stigmas. Some patients may be diagnosed with HIV for the very first time at the same time as their Kaposi's sarcoma diagnosis. So they might be getting an HIV diagnosis and a cancer diagnosis in the same day, or they may have been living with HIV for years and then have gone on to develop Kaposi's sarcoma. The cancer diagnosis is usually new. In addition, the Kaposi's sarcoma is often presenting with visible skin lesions that may put people at risk for stigmatization. And the manifestations of these 3 intersecting stigmas have the potential to impact healthcare engagement on many levels, including delayed diagnosis and treatment of KS. So stigmatization of these illnesses creates barriers to health equity and potentially decreases quality of life. And with that, I'd like to pass it over to my colleague, Dr. Sigrid Collier, to take us through the analysis that we did.
So I think next slide. In order to explore intersectional stigma in HIV-associated KS, we used a convergent mixed methods approach. This was nested within a longitudinal cohort of incident cases of HIV-associated KS in Western Kenya, within the academic model providing access to healthcare, or AMPATH healthcare network. So for the quantitative portion of our mixed methods approach, we administered 4 adapted versions of the Berger HIV stigma scale to measure overall stigma, HIV-related stigma, cancer-related stigma, and skin disease-related stigma. We administered these every 16 weeks over approximately 2 years among 117 participants. We simultaneously selected 88 people with KS proposively based on the stage of KS at the time of diagnosis and also their treatment status. And then they participated in in-depth interviews. During the interviews, they were asked about stigma and how it had impacted their experience following KS diagnosis. And we specifically asked probes about stigma as a barrier to diagnosis of KS, initiation and adherence to chemotherapy, and then also this intersection between HIV-related, cancer-related, and skin disease-related stigma. We analyzed the qualitative data using framework analysis with a priori constructs from the Health, Stigma, and Discrimination Framework, which we heard about earlier. And then we also allowed for emergent themes in our analysis. So the next slide shows our joint display in which we put together the qualitative and quantitative data in sort of the same display. So the quantitative results are represented as the proportion of responses with moderate or severe stigma for each of the constructs. And representative quotes for each of the constructs are in the callouts extending from each of the pinwheels. As you can see, the proportion of participants with moderate or severe stigma was similar across HIV, cancer, and skin disease. However, the qualitative analysis revealed a much more complex story. Many participants described experiences of HIV-related stigma and specifically anticipated stigma around HIV disclosure. Cancer-related stigma and skin disease-related stigma were less commonly expressed, though they were still an important part of the lived experience, and we'll explore this further in depth in the next couple of slides. So on the next slide, when we start talking about perceived stigma in this population, it was much more common for people to talk about perceived stigma with HIV. And as one person said, I was not afraid of cancer, but HIV. It is still a strong name. Even now, people see cancer as a normal thing, but HIV, it is a bit different. So as you can see, they're sort of saying, you know, cancer is a little scary, but HIV is really scary. And then when they're talking about skin disease, they describe that there's this perception in the community that there's fear and pity from community members related to skin disease. So on the next slide, anticipated stigma was commonly also related to HIV more than cancer. So you'll see this is similar. And one person said, up to now, I don't want them to know that I have tested positive for HIV, but I don't mind them getting to know about cancer. So they were very worried about disclosure of their HIV status and less so about disclosure of their cancer diagnosis. Similarly, many of the participants described covering up their skin lesions to avoid disclosure of their disease. So on the next slide, we'll talk about the experiences of people with stigmatization. And for HIV and skin disease, there were often severe experience consequences of the stigmatization. For HIV, one person described, whenever I went to take my medication, my wife would throw them away. So it got to the point where I just got tired and quit taking them. When she saw the state that I was in, she left. She left the children and went away. Similarly, for skin disease stigma, what I feared the most was how people were speaking to me. People didn't want me where they were because my leg was smelling. And one person said, my boss fired me because of these wounds. So these wounds were bleeding so much. Interestingly, when they were talking about cancer, they described more that there was negative consequences because of social isolation from the financial burden of cancer, rather than specifically stigmatization around the cancer diagnosis itself. So on the next slide, for HIV and for skin disease and for cancer, there was sort of this devaluation of their lives and themselves related to their KS diagnosis. And that included sort of suicidal thoughts, though it was most explicit that they described this in skin disease. So one person said, I had some wounds which were discharging. I was stinking. The condition was ashaming me. Not that the friends were discriminating against me, but I felt within myself that it was not good to be around where people are. So on the next slide, we'll kind of talk a little bit about the qual and the quant together again. And in the interviews, participants clearly described delaying their diagnosis to avoid being around people because of their KS. They also described delaying treatment because of fatalism, thinking that they were going to die anyway. Interestingly, the stigma scores seem to decline over time following KS diagnosis from the quantitative analysis, and there are hints from the qualitative data that this may be related to skin lesions becoming less visible over time and people's overall health improving. So in conclusion, next slide. Although HIV-associated stigma was a huge part of the KS stigma experience, cancer and stigma were still an integral part of the holistic experience and contribute to a more complex, severe, and damaging experience of stigma and HIV-associated KS. I'll hand it back to Esther.
So in conclusion, the experiences of HIV, cancer, and stigma and skin disease are really intertwined in the everyday experience of our patients. Many stated that HIV-related stigma practically nullified their other potential sources of stigma, such as cancer, while others still felt more stigmatized because of the combination of HIV, cancer, and HIV, cancer, and skin disease. So really our key conclusion is that for people with KS, identified HIV-related stigma as a central barrier in KS diagnosis and treatment. And with that, we'd just like to share the paper that we've published on this, which is now out in open access in JIIS. And also thank you to our funders, in particular to the NCI and to the supplement to our U54, which allowed for this work. Thanks so much for having us.
Thank you so much. And now we're going to hear from Mr. Austin Waters, who's a doctoral student in health policy and management at the University of North Carolina at Chapel Hill. He has a background in public health, sociology, and cancer health services research at Huntsman Cancer Institute in the University of Utah. So please.
Perfect. Can you see my slides, Dr. Dean?
Yep.
Perfect. All right. So as mentioned, my name is Austin Waters. I use he, him pronouns. I'm a doctoral student in Department of Health Policy and Management, and today I'll be talking about the financial burden and mental health among LGBTQ adolescent and young adult cancer survivors. So a little bit of background, the LGBTQ community makes up about 7.1% of the US population, over 23 million individuals. And LGBT populations experience disparities in economic realms, in health-related, mental health, physical health, but experience economic instability due to lower incomes, in part due to employment discrimination. LGBT populations face identity-related as has been defined throughout the day. But in this context, the co-occurring of labeling, stereotyping, separation, status loss, and discrimination in the context of power. So when thinking about stigma in this case, in the LGBT population among AYA cancer survivors, we're thinking about social policy, community level attitudes, and neighborhood level hate crimes. So I've just populated a handful of recent headlines from news articles that kind of illustrate a little bit of what kind of stigma I'm talking about today. So then a little bit of background on adolescent and young adults. Adolescent and young adult cancer survivors are diagnosed between 15 and 39 years of age and often have very few services offered to them in the cancer care setting. They're diagnosed at a dynamic time of life in young adulthood, which is compounded by LGBTQ identity formation, which often happens during this time frame. Both LGBT and AYA survivors are at higher risk of financial burden and mental health challenges, but the impact of intersecting identities and outcomes remains largely unstudied. So I also wanted to briefly go over the framework that I used to study financial burden in this study. This is the Altice framework, came from a systematic review in 2017 that broke financial burden into 3 distinct categories: material conditions, psychological responses, and coping behaviors. You can see here listed below each domain, the outcomes of those domains, right? So things in material conditions like out-of-pocket expenses, missed work, reduced income, those like real tangible money outcomes, psychological responses, stress and distress due to cancer related cost concerns, and coping behaviors. The ones listed here are quite medically focused, but I'll also discuss a handful of other coping behaviors outside of healthcare utilization. So the study aim was to describe how the COVID-19 pandemic, cancer treatment, LGBTQIA identity-related stigma impacted LGBTQIA survivors' financial burden and mental health. To do this, we also used a mixed methods design, but a sequential explanatory mixed methods design with an emphasis on our qualitative explanations. For our quantitative section, we used a survey of 325 AYAs. It was the COVID and Cancer survey, to look at differences between LGBT population in that survey and the non-LGBT population, focusing on our outcomes of interest being financial burden and mental health. We then conducted in-depth interviews with 9 of the LGBT AYAs from this survey, and conducted interpretive description on those interviews. You can see here right on the right a little methods figure. Here we have our data integration figure that can be quite overwhelming, but makes conceptual sense when you break it down by column. So on the far left are outcomes of interest, as I've mentioned, are financial burden and mental health. On the far right are outcome measures or frameworks used to conceptualize or capture those outcomes. So first, the financial burden quantitative measure being the comprehensive score for financial toxicity or cost score. And then the material financial hardship or the material hardship domains that I mentioned from the Altice framework being used to deductively code through interpretive description of the qualitative results. We also had in our COVID and Cancer survey 3 measures of mental health. So perceived stress scale, that was a short version of perceived stress scale 4, a promise anxiety score, and a custom promise depression score. We also had some emergent mental health qualitative findings as well. And then through the middle, we'll go through these results in the next slides. So first, I want to talk through some of the financial hardship and financial toxicity domains that were mentioned in these, both in our quantitative and qualitative findings. First, on the left in our quantitative findings, we can see that LGBTQ AYAs have significantly worse financial toxicity than the cisgender heterosexual counterparts. The cost score is scored from 0 to 44, with higher scores indicating better financial toxicity, so lower scores are worse. Most cancer centers' financial navigation systems use 21 as a cutoff for severe financial toxicity in need of navigation. You can see here that the LGBT cancer population in this sample had a mean score of 14.9, which is quite low. And then to contextualize these findings, you can see to the right some of the quotes that surrounded material and behavioral financial hardship. Folks talked about being barely able to afford rent at the time, rent and cancer treatment, all of that at the same time. We had individuals who talked about discrimination and stigma in the workplace. One person saying that they had a customer here and there that were just like, oh, you fucking faggot, you know? We had other participants say that their husband had to take care of their bills while they're much more major and needed more attention, also because their health is important. But we still need a roof over our heads to demonstrate the severity of the financial burden. And we had a couple individuals in our interviews talk about stopping treatment because of loss of insurance when they lost their job. Job loss was due to their cancer, but also in some instances due to LGBT identity. In this sample, we also had individuals that were not out of with their LGBT identity to their family, friends, and healthcare providers, and refused to come out because they feared losing financial support. We also had a couple participants of color who mentioned that they did not come out to their family, friends, or healthcare providers because they already lived in more conservative areas and faced racial discrimination. So then when we go think about our mental health outcomes by LGBTQ status, you can see here in the left part of this figure, promise anxiety, promise depression in the middle, and the perceived stress scale 4 on the right, that LGBT populations again fared worse on all of these measures. In pairwise T statistics, you can see that LGBT populations have substantially high promise anxiety and depression scores in this sample, which can be contextualized in this being an AYA and LGBT intersecting population. So some of the quotes from the qualitative section of this analysis, focusing on psychological financial hardship as well as mental health. One participant said, "I had nothing left in my life after coming out and going through treatment, and I was lonely, it was hard, and it was scary, and it was painful." This individual had lost acceptance from family during this time, had moved out and into a friend's home. It was a traumatic time of life for them. Another participant, so I think it's impacted the COVID-19 pandemic in terms of thinking like, okay, well, what if I do get really sick and I'm not able to work? There was a constant level of stress felt by most participants around getting sick during COVID, whether they were on active treatment or not. They feared that inability to work moving forward. Another participant said, after all of that loss due to non-acceptance, I kind of started self-medicating because why not? This one individual started using IV drugs during this time as a coping mechanism, as after they had lost a lot of family and friends due to coming out in their LGBT identity during their cancer journey. The last participant said, so many times this year I got put into a box that I didn't belong in. All these boxes, everybody shoving me in, and I was like, don't put me in your box. This is my new thing, but they keep putting me in a box, not fair. This participant and one other participant expressed suicidal ideation during our interviews, which were connected to psychological resources, but was not something that we expected to emerge during these interviews. Often these suicidal ideation thoughts surrounded around the mental health impacts of cancer and being an LGBT cancer survivor during COVID. Great. So then some of the conclusions. This highlights the complex and intertwined nature of financial hardship and mental health and the impact of COVID-19 and stigma on an economically unstable group. LGBTQ AYA survivors face worse and unique financial hardship in comparison to their non-LGBT counterparts due to intersecting structures of oppression. And LGBT individuals with more diverse identities that experience intersectional stigma may face even worse outcomes than those with less diverse identities. And then some thanks to the study teams.
Thank you. And finally, our last panelist is Dr. Andrew Dykins, an associate professor of family and community medicine at the University of Illinois at Chicago, and the director of global health equity implementation research at the UIC Center for Global Health. He's also the founder and director for the capacity building platform at the Consortium of Universities for Global Health. So please go right ahead.
Okay, great. Thank you so much. Can you confirm that you can see my slides, please?
We sure can.
Thank you so much. Well, it is absolutely an honor to be with you all today. I really appreciate the invitation. This has been an extraordinary day. I've learned a great deal, and it's been really amazing, and I'm looking forward to tomorrow as well. So thank you for the opportunity. I'd like to talk to you today about some work that I and colleagues have been doing in Senegal since 2010, focused on addressing the role of gender in perspectives of stigma relative to cervical cancer in rural Senegal. There we go. Okay, I have no disclosures. And I would look to acknowledge Fogarty International Center, the data that I'll be sharing with you as a part of this presentation come from a KO1 that was awarded through Fogarty, and also mention some follow-up work that we've just now started on through a R01 that's being funded by the National Cancer Institute. So as I mentioned, we've been working since 2010 in the far southeastern region of Senegal. We've also done some work in Tambacounda, but what I'll focus on today is Kédougou. And we had initially been building capacity working with the University Cheikh Anta Diop and the Ministry of Health and Social Action in Dakar, focused on cervical cancer screening. Prior to our initiation of our work in 2010, no rural region had access to cervical cancer screening services. And this was a locally identified issue that we've been thrilled to work with. And we noticed after a few years of building capacity that our uptake for the screening services was quite low. To give you an idea of the region where I'll be talking about today, it has a population of about 172,000 people with 26 health posts and 3 health centers. It's quite rural. There are 3 districts, and our project today covers those 3 districts. There's a significant shortage in workforce capacity in this region with 48 midwives principally providing the access to cervical cancer screening services in this region. In terms of cervical cancer globally, there's about 500,000 new cases annually. About 90% of the deaths for cervical cancer occur in low and middle income countries. And many women in low and middle income countries remain undiagnosed and have limited or no access to treatment. To give you an idea of correlation, in 2012, the US had an incidence rate of 8.1 per 100,000, and the low and middle income countries collectively had a rate of about 15.7. As you can see here, the 2018 data for Senegal shows a 37.8 incidence rate per 100,000. It places it 17th in the world. And there's about 1,900 cases annually with about 1,400 deaths annually. It is the #1 cancer killer among women in Senegal. And so it's just representative of equitable access. That equitable access to many women's health services is lacking in low and middle income countries, especially in cancer prevention programs. And given that there have been high evidence-based solutions to cervical cancer prevention for decades, the fact that these screening services are not accessible is really problematic in these settings. Sorry, I'm having a problem with my notes. There we go. Okay. All right, so you can see a little bit of the distribution of the age standardized incidence rates globally, just to give you an idea. You can see here that Western Africa follows the dotted or the dashed line, and Senegal somewhat outpaces its peers geographically in terms of the incidence rate of cervical cancer. In Senegal, there is a significant lack of screening, essentially. So building capacity in these rural regions needs to be followed up with programs that encourage the uptake of these services. And that's the impetus for developing this project, where we've been working with women's groups in the rural region to understand the barriers to uptake of cervical cancer screening services. And we're really interested we were at this time really interested in understanding multi-level barriers so as to inform a future multi-level intervention, which I'll talk to you about in a bit. This is the population that we were studying across 9 demonstration sites listed on the left, giving you an idea of the number of villages being serviced by these posts and district centers, and the midwives that are available at each of these locations for the screening access. We did a cross-sectional survey of 160 participants, 101 women and 59 men, ages 30 to 59. Across the 3 districts and these 9 rural sites, we had men, women, couples, as well as some independent women within the women's care groups to provide the responses to the questions. We noted that there was intersectional stigma in this population, principally something that we had hypothesized that there was gender stigma in the form of gender-based structural violence across multiple levels, which I'll go into, and then cancer stigma. And we had adapted the everyday discrimination scale as well as the cancer stigma scale as part of our data collection efforts. And so in terms of gender stigma, I'm just going to go over briefly some of our findings that correlate across the levels that we identified. The interpersonal, we identified a lack of education or knowledge, and especially among women. At the interpersonal level, there was gender imbalance and a lack of autonomy and decision-making. And then at the community societal level, there was gender inequality and gender discrimination. So you can see the demographics of our patient population, and the majority of the women did report being in a polygamous relationship, and there were, more females than males that had no education at 25.7% versus 10.2%. In terms of perceived gender roles among women, 59% strongly agreed that a woman's most important role is to take care of her home and cook for her family, while among men, 43.9% agreed and 40.4% strongly agreed with this statement. Concerning a man's role, 53.5% strongly agreed that a man should have the final word about decisions in his home, while among men, 69.6% strongly agreed. Among women, only 16% felt that they have the final say at home regarding their healthcare decisions. In men, 79% agreed that they had the final say in their own healthcare decisions. Whereas if we look at the inverse statement, among women, 72% felt that their spouse has the final say at home regarding their healthcare decisions, and in men, 9% agreed with that statement. So this illustrates the implications of this decision-making, whereas women more likely trust the input of their family members, whereas men more likely trust the input of healthcare providers. In terms of discrimination, significantly more women than men feel treated with less courtesy or respect by their spouse from a few times in their life to weekly or daily. So looking at cancer stigma, at the interpersonal, we identified personal shame, and at the interpersonal levels, personal stigma and perceived public stigmas. In terms of shaming and blaming, among women, 27% strongly agreed, while among men, 1.8% strongly agreed that if a person has cancer, it's probably their fault. Among women, 25% strongly agreed, while among men, only 1.8% strongly agreed that I would not feel comfortable around someone with cancer. Among women, 57% strongly agreed, while among men, 8.9% strongly agreed that once you've had cancer, you're never normal again. Women, 32% strongly agreed, and men, 5.4% strongly agreed that healthcare needs of people with cancer should not be prioritized. Among women, 50.5%, and among men, 16.4% strongly agreed that cancer is more frightening than most other diseases. And among women, 48%, and men, 7.1% strongly agreed that women often state that they are worried about cancer. So you can see this differentiation between the genders relative to personal stigma. And this carries over to a perceived public stigma as well. Whereas among women, 18% disagreed and 10% strongly disagreed, while men, 30.6% disagreed and 1.8% strongly disagreed that if I had cancer, I would want my family to know that I have it. So women were much less likely to want their family members to know. And among women, 25.3% disagreed and 4% strongly disagreed, while among men, 0% disagreed and 1.8% strongly disagreed that if someone else in my family had cancer, I would want to know that they have it. So there are these perceived public stigmas that go along with this that we've identified in this setting. This is just a picture of the care groups with whom we were working through this process. We're taking this information and trying to apply it to next steps. Right now, we're funded for a patient navigation program, and we're exploring the opportunity to study a gender transformative approach as well. In terms of the patient navigation program, we're looking here at adapting the Chinatown patient navigation program from the US context into this context. We're looking at a multi-level model can see here on the upper right-hand side that the identified barriers that we're looking at include stigma and women's autonomy to decision-making. We're using the dynamic adaptation process and the EPIS framework to study the adaptation of this intervention with community level navigators seen here at the bottom, as well as district and regional level navigators overseeing their work. Our community level navigators at the health post level are lay workers, and they will be principally associated with helping with outreach and encouraging women to seek cervical cancer screening while addressing the multi-level barriers that they're facing, with a special emphasis on stigma, gender imbalance, and women's autonomy in decision making. And you can see here that the intervention is carries across multiple levels and across the cancer care continuum. So thank you so much. We're excited to see what the results from this future study shows, and we're looking forward to continuing our work in this area. So thank you. I really appreciate your time and the honor.
Thank you. And now I'd like to invite the panelists to turn their cameras on, if you don't mind. Excellent. So we do have a few questions in the chat, and I think we'll go in presentation order to start with. Let's see. For Esther and Sigrid, how can we address intersectional stigma in these vulnerable populations?
Yeah, I think, thinking about, it's one thing to kind of name the stigma and say what's happening, and then quite another trying to figure out how to target interventions to really improve it. So I appreciate the question, because I think, as we heard this morning, one of our speakers say, kind of, so what's next, which is really the important question. So I do think that, it's going to really require multi-level interventions, especially when you're dealing with people who are stigmatized on so many different. I was really interested to actually hear about Andrew Dyken's work, because one thing we're doing right now is we do have a multi-level patient navigator approach. And what we've found is that our patient survivors, especially in the Kenyan context, have been much more powerful than kind of anything else that we've done. Hearing from, so we actually have survivors who function as our patient navigators, and that's been really, really powerful for our patients, because they, literally have someone who says, "I've been through it, I survived, I worked through it, I made it to these appointments, you can do it too." And that has actually probably been the most powerful tool that I think that we've seen. But I defer to Sigrid if you had anything to add.
Yeah, I guess I would say from like our preliminary analysis of, we're doing qualitative interviews around the interactions between the peer and the patients, and it seems like it's really impacting the cancer stigma. And I think, and making them believe that they can survive. It'll be interesting once we get a little further along in this analysis to see what it does for the HIV related stigma, because my impression from talking to the team and the peers is that there's so much hesitance to even talk about it that I'm unclear that the patients are even willing to talk about their HIV status with the peers, even though the peer also is a person living with HIV. And I'm not sure whether the peer would be comfortable talking about it at all, because there's so much stigmatization. So that is a complex issue, and I'm really not sure how to dispel the myths, around that. So
I was curious, can I actually ask a question of one of our fellow panelists? I'm sorry, I couldn't type fast enough to get in there. Because one thing that we've struggled with in our study that I was curious for my fellow panelists, when we're measuring sorry, I'm totally jumping in. When we measured intersectional stigma, one thing that was really tough for us was that for the quantitative measurements of not getting patients just to respond the same way each time. If you're asking them multiple ways or multiple times about their stigma, and you're saying, okay, now I want you to think about your HIV stigma. Now I want you to think about your cancer. Now I want you to think about your skin. In a lot of cases, I think patients were kind of tempted to just kind of get frustrated by being asked similar questions multiple times and kind of give up. And then we got much more richness out of our qualitative data, because we could really kind of delve into these issues. So I was just curious for our other panelists, did you have success in quantitative portions and kind of trying to tease these things out? Because we found it harder in quantitative and easier in qualitative.
Yeah, I can answer to the best of my ability for that. We didn't really attempt to measure the intersectional stigma through our quantitative measures. It was really, we used the quantitative measures to capture the outcomes and knew that we would need to do qualitative work to understand how like the different like confluence of structures and stigma are like influencing and pushing those outcomes. And so I think from the get-go, we knew that that would be maybe outside of the realm of especially trying to build it into a different survey as well. Yeah.
Yeah, and we on the flip side actually did not collect qualitative data on these particular questions for this project that I presented, but we are using mixed methods in the R01 that we have moving forward, and we're just in the early phases of that. So we're actually really curious about what we're going to find, and we're hopeful that the qualitative piece will inform robustly the patient navigation, the adaptation of the patient navigation program to respond to those issues.
I'll point out that maybe this is helpful. In BMC medicine, in the same volume that Anne's paper on the health stigma and discrimination framework paper was in, there's also a paper on challenges and opportunities in examining and addressing intersectional stigma in health. And I think they talk specifically about that issue, Esther, is the measurement issue, and make some recommendations for how to address that specific issue of getting, when you ask about stigma related to, and how you ask about stigma related to a particular aspect of identity. So I think that might be helpful. I'm sure that others have, maybe others who are participating in this meeting have some other good suggestions of resources for measurement. I want to skip out of order just a little bit, and I think we've got time. So Esther and Sigrid were talking about a patient navigator program, correct? Yes, and yeah. Andrew, I think you were describing a patient navigator program as well. And if I'm not mistaken, the Chinatown project is a navigator program. And we do have a question about that. Can you explain, can you describe it briefly? And then there was another request for clarification on women identifying as polygamous and men monogamous in your study sample. So 2 questions there.
Sure. In terms of the Chinatown Patient Navigation Program, so basically it was a program that was implemented in Chicago and uses lay navigators, which was why we were very interested in adapting it into the Senegal context. Basically, it responds to helping to promote self-efficacy, sustaining the engagement with care, and enhancing access to care. So it works at multiple levels, from health education to identifying various types of barriers, structural and otherwise, and then helping the patient overcome those barriers to not only access initial preventive services, but also advance along the care continuum. And then you'll have to forgive me, specifically the additional question was related to the polygamous relationships. Essentially, that was just a component of the demographics of the area. The majority of men reported being in monogamous relationships, whereas the majority of women slightly did report being in polygamous relationships. It was just one of the components of the demographic data, in addition to the educational piece. Not sure if that clarifies the question.
I think that's got it. Thank you.
Mhm.
Austin. Let's see. There were a couple of questions about oh wait, did somebody have their hand up? Sorry, I'm trying to track the chat and see if there are any questions that have come up.
This is Anne. I had my hand up. I just wanted to jump in on that measurement question about intersectionality. I think what I was just typing in the chat is that the jury's really still out. This is very new. Like there's a lot of grants that are working, going on in different fields, HIV and cancer, to try and develop measures. I've had a doctoral student who had some success with the specific, she was looking at sex work stigma and PrEP stigma and HIV stigma. And in her case, she measured all of those separately and then put all the items together into a factor analysis. And then the PrEP stigma ones didn't work, but the HIV and the sex worker stigma ones actually went together very well. And you could see them falling out in subscales by domain. So stigma domain, like internalized stigma. And so that's an idea that might be one way of doing it. That paper, she has not published that paper yet. But there are others who are using the broader stigma scales, like everyday discrimination. And I think that, Andrew, you said you may have adapted that one, and sort of using these broader scales to capture just stigma and discrimination experiences in general, and then sort of quantitatively trying to look at, which identities does this person have also, or which, and getting at it analytically. But I don't think we have a great way yet to say like, hey, this is what everyone should be doing. So I think I would just say, keep at it. I think the qualitative research is extremely important. So Austin, I think the work that you presented was really fabulous and heartbreaking, but really, really important, I think, to see. So I just think mixed methods for now has really got to be the way that we approach this. And I think also that Sigrid and Esther, you also did that, right? You tried both things and you learned a lot from that qualitative that wasn't coming out of the quantitative. So I think that's maybe the best we can do right now. I'm sure there might be others on the call who, like Laura Nyblade, who might want to chime in, but that's what I would say. That's kind of the latest that we know for now. Thanks.
And I think the paper that I mentioned, and Greg Greenwood actually put the link in the chat. So thank you for that. Also mentions the importance of using mixed methods in this research area. Austin, Katie had asked about hearing your thoughts on potential ways to address the confluence of mental health stigma, cancer stigma, and gender and sexual identity discrimination and prejudice. And I want to give you the floor to talk about data.
Yeah, absolutely. Yeah, I responded briefly in the chat, but we'll reiterate and get a little bit more detail. I think the first thing, and kind of a hiccup when trying to start studying this topic in general, is that sexual orientation and gender identity are not routinely and systematically collected in health systems.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.